Oh Oh Avinash, can you hear me? Avinash.
Yes, ma'am. Hello. Hello, yes, ma'am. Am I audible? Hello. Yes, ma'am.
Am I audible, Avinash?
Yes, ma'am. You're audible.
Okay. So I think for the time being, I think everyone should put on mute. Hello.
We can start now.
So good afternoon, everyone. On behalf of Gynae Disease Management Group, Maxcon Institute of Cancer Care, Saket, I welcome you all to this scientific spectacle. The DMGs, the disease management groups, they have basically bridged all the gaps of the doors through which a patient walks in. So let's make this scientific forum a mega DMG where all the faculty and the delegates bring their experience and knowledge to do the best for the patients. Along with it, we have added a few flavor of the latest what's going in the world. So I welcome you all to the Gynae Maxcon 2021 Quest for the Best. Thank you. And now I would like to invite Dr. Harit Chaturvedi, who is the chairman of Max Institute of Cancer Care, Saket, and is also the chief patron of this conference. Over to you, Dr. Harit.
Thank you, Dr. Charu, for having me here. Thank you, the Gynae DMG team, for organizing this wonderful event. I can see how compactly you have created this 8 hour of engagement with faculty from across the globe and almost covering various aspects, including surgical videos and debates and gray zones. It's really an amazing, and also the kind of faculty you put together. Doing this, I have seen this from a distance. It has been very exciting for me to see all of you engaging in discussion, debates, arguments, to get the best. And that is really the quest for the best, which I see every day coming out through these debates and discussions. So thank you very much for organizing this. And I really want to, from the bottom of my heart, I want to thank the senior faculty for taking their time out and coming there, because this is the platform where the new oncologists learn, discuss, debate, and the ideas get transmitted from one generation to other generation. The continuous environment gets created of bringing the best knowledge to the platform and to the patients. So that is what it is. And it was really very heartening to learn that you have got 75 abstracts submitted for the conference. That was really an eye-opener for me, that what so much is happening around us, so much is being captured around us, that every coming day is better than what we are living today. So that is what is our continuous quest, and I'm sure you will achieve these milestones step by step. So thank you, and carry on. Thank you.
Thank you, sir, for your encouraging words. To start our scientific conference, we have our first session, and we start from the basics. It's a pleasure now to invite our moderators, our chairpersons for the session. The first session is a panel in gynecology. I invite Dr. Bela Makhija. She's a Senior Director, Obstetrics and Gynecology at Max Smart Super Speciality Hospital, Saket. I also invite Dr. Meenakshi Chauhan, Professor, Department of Gynae Obstetrics, Pandit B.D. Sharma, PGIMS, Rohtak, and our very own Dr. Sunita Malik, Professor and Consultant at the Vardhaman Medical College and Safdarjung Hospital, Delhi. Dr. Sunita is presently very closely associated with oncology. She's the chairperson of oncology at the AOGD, which is the Delhi Foxy Group. I welcome you, ma'am, and you may please start the session.
Thank you, Dr. Manas, Dr. Chaudhary, Dr. Batra, for inviting me over for this valuable, prestigious conference. And I've been the opening batsman of this. I wish this conference goes on very well. The way the program is, I'm sure it will be going well. So what we have is, I'll just introduce the moderator of the panel discussion on post-menopause breeding. That is Dr. Brigadier Aruna Menon. She is Professor and Head, Department of Obs and Gynae, Armed Force Medical College, Pune. Over to Dr. Aruna for starting the first session of today's conference. Should I introduce the panelists also, or the
No, I'll do that, but I think my video is still not.
Request
Okay.
the moderator, Dr. Aruna Menon, to.
Yeah, of course.
Am I visible?
Yeah.
So good
Yes.
evening, and very heartfelt thanks for having me on this forum. It's wonderful to see Rita Vishwas, and we've had a long association. But without wasting too much time, I would like to call on my panelists. I have a very good panel of across the country. So first of all is Dr. Vani Malhotra, who's professor at PGIMS Rohtak. She's joined by Dr. Jayashree Sundar, who's a director at Madhukar Rainbow Children and Children Hospital. Dr. Vaishali Kode from very own Amchi, Pune, who's consultant at Critical Care Obstetrics Ruby Hall Clinic and also at Maimar Medical College. Dr. Payal Singhal, who's the senior consultant Obs and Gynae at your own Max Hospital, and Dr. Shiva Marwa. So are all of you online? I can't really see everybody. Are all the panelists online?
Dr. Jayashree here.
Yeah, right. And
Dr.
what about
Vaisali
the
and
others?
Dr. Vaisali and Dr. Siba will be joining soon.
Okay. So I'll start by sharing my screen. We are going to talk about postmenopausal bleeding, of course. So it's a problem. I mean, it's something that we all face in our day-to-day OPDs, and it's a very welcome prelude to the entire conference that is going to go on. And so for the first, we have decided to discuss it case-wise with case scenarios. So we'll start with the first case. So Dr. Jayashree, then will you take it? Otherwise,
Yeah, surely, Doctor.
So we have the first patient, who is Mrs. Z, 65 years old, postmenopausal for 16 years. And she's presented with just one episode of spotting PV. Her general condition is fair. She's, however, on examination, her vagina is a little hypoestrogenized. Cervix is pinpoint, but otherwise normal. Uterus is postmenopausal size, anteverted, mobile, and the adnexa are free. She has no PO-date episodes on PR. So my first question to Dr. Jayashree, how would you go about evaluating this patient?
So as Dr. Aruna said, so I'm dealing with a 65-year-old. Obviously, the history is very important for me, whether she is on any medication, whether she is on any blood thinners that she is on, any change of medication, any urinary tract symptom, whether the bleeding was really from the vagina or from the urinary bladder or somewhere else. So a thorough history is very important. And once I have seen this patient, I excluded all other causes and I'm looking at a uterine cause. The first thing, obviously, I would offer her in my OPD is an ultrasound to be transvaginal ultrasound to be done. Sometimes transvaginal might be difficult, so we might offer her an ultrasound lower abdomen, and I will look at the lining of the womb first. Along with it, I'll take her pap smear. Obviously, she is 65. This will be her last pap smear if she has had pap smears before.
That's right.
And obviously, if I can possibly take an endometrial biopsy sample in OPD, I would be very happy to take an endometrial biopsy sample, because the tissue diagnosis is very important for further course of action in such a patient.
So suppose we've done everything that you said, and yet the tissue sample is inadequate. I mean, that is what what would you do next?
So now then I will correlate it, then I will be a bit reassured. If I have done a good job at pippling a sample and it's not coming, it is very unlikely that I would be missing out cancers in such patient, because usually pipple sample gives us a diagnosis. Then I will look at the lining of the womb in this woman. So if I see that the lining is less than 4 millimeter, then I would still, if I feel the symptoms are there, because there are 10% of cancers, or I'm not exactly sure about the number, which may have an lining very scanty, but still there might be cancer.
Yeah.
Then the gold standard is
these are all screening. I mean, these are not 100% accurate. So, and though they approach 98%, the gold standard would still be in the hysteroscopy. In fact,
Putting in a camera. So it is like looking in to see what is there in. And once we see that, then we can be more reassured that the
In
patient.
fact, one of the indications for doing a hysteroscopy itself would be that you have not been able to sample it.
Identify anything. True.
Yeah.
So I could
or if it is non-diagnosed. Yeah.
Yeah.
So, so now you've done hysteroscopy. It is still an atrophic endometrium. The uterine cavity is absolutely normal. You don't find any polyps. Now, what will you tell the patient?
So I think this patient, the bleeding might be due to an atrophic endometritis, right?
Yeah.
So if there are no other risk factors in the patient, I would put her on a short course of local estrogen to help her with the building of the tissue, vitalizing the tissue, and that should be what that is needed for her. But obviously, I have to look at her medical condition before I offer this thing to her.
Yeah.
And I will more or less reassure her that there is nothing wrong with it. I think at this age, it is very important for a reassurance.
Yeah. And maybe you can advise her to come after 6 months in case she is symptomatic.
Yeah, she keeps a follow-up. Right?
Yeah. So I think this is one of, it's a very common scenario that we see in the OPD. We'll now move on to have any of my other panelists logged in? If I could, I can't see all the.
Is Dr. Vani is here?
Yeah. Okay. Dr. Payal, I thought I saw her in the.
Yes, I'm here.
Payal, are you here?
Dr. Aruna, I'm here.
Yeah. Okay. Okay. So now we move on to the second case. So she is a 60-year-old woman who's presented with history of bleeding PV off and on for a month. Okay. So now what all would we ask her in history and examination? Dr. Payal, you can take it on.
So we need a composite history in patients with postmenopausal bleeding. You need to find out how long she's been menopausal for. A late menopause does predispose you towards malignancy, and also how many children she's had, the parity, whether she's nulliparous, and how long the bleeding and what is the quantity of bleeding. Light bleeding tends to go towards atrophic endometritis, whereas heavier bleeding predisposes you towards malignancy.
Yeah. Basically a very detailed history, and it should also include any drug history if she's been on any kind of medication or any kind of formula. Nowadays you have so many formulations which are even available over the counter. So that's a very important history. Any history of any malignancy or anything like that, which she has had earlier in the past, and any history of any other indicators where she might be a high risk for what we are now looking at is possibly a case of C endometrium. So we would like to look out for those risk factors. Now, this patient on examination, her cervix is healthy and it's flush with the vagina. The uterus is anteverted, normal size, mobile, the adnexa are free and POD is free. Now, what investigation would you like? It's almost a repeat of the previous case, so we can go past that a little faster.
We basically would need a pap smear, a transvaginal scan for looking at the endometrial thickness, any polyp.
So when we talk about transvaginal scan, is there any correlation between TVS and maybe the possibility of endometrial carcinoma? That is the thickness of ET and malignancy. What is the correlation?
So if you have an endometrial thickness which is less than or equal to 4 millimeters, it generally rules out majority of endometrial malignancies, because 80% of the cases are endometrioid cancers, which generally are associated with a thickened endometrium. Okay. However, non-endometrioid cancers are associated with atrophic endometrium and seen more commonly in the African women. So in such patients, you probably, despite the endometrial thickness being less than 4 millimeters, you might still have to continue, have to get a tissue diagnosis.
Yeah, so that is one thing. Any other modality or any other diagnosis which is aided by doing a TVS, which could again just be the cause of the postmenopausal bleeding?
The adnexal masses, that is an ovarian cyst.
Anything, Dr. Jayashree?
I would look for polyps and fibroids.
Polyps
I would also look at the vascularity when I offer her a TVS scan. The vascularity also gives us a significant indication of the growth of the tissue. So I would look at that also when I'm doing
TVS, as far as postmenopausal bleeding is concerned, the ET and the presence of any polyps or any
Fibroids.
Yeah. So that is a very important way which you can rule out and decide on what to do next. What about the various causes other than right now we are veering towards C. endometrium, but what are the other causes that you can think of other than C. endometrium?
So we've talked about polyps. Then if you can also, there are other reasons are, it could be a fibroid. It could be things like tamoxifen or anticoagulants, or even soya preparations, if taken for long, can cause endometrial hyperplasia. Then any HRT which was being given to the patient. And other causes could also be trauma. If she's using a vaginal pessary, could be a foreign body, which would be.
Yeah, that's a very important thing that we should look for, because that actually, once you find it, you can treat it by just removing it. Then other causes like pyometra.
IUCDs also. Women forget that they have an IUCD inside, and I've seen postmenopausal bleeding with that too.
So they may have just forgotten about it and not ever had it removed. So that could be one of the reasons. Then other cancers of the vaginal tract itself, and also any symptoms that are related to the neighboring organs. She may mistake it for, like, she may be having piles or some other pathology which is related. So it is very important for us to do a thorough local examination, not only genital and gynae examination, but look at the other organs as well. So when we talk about C. endometrium, what would be the risk factors that we would look for in the patient?
Shall I take this question?
Pardon? Yeah, please.
Yeah. So the first thing would obviously, in the history, I would look at obesity is a very big factor. Diabetes is a very big factor. Early menopause, early menarche, late menopause is a very big risk.
So the corpus cancer syndrome is a very important risk.
And there is so we have to rule out all these things in that woman, and we should have a higher index of suspicion when we are dealing with such women as we are treating them. Yeah. So hypertension, diabetes, obesity, and as you said, and also if there is any family history of bowel cancers and ovarian cancers in the family, if she has been treated for breast cancer earlier, that is also a risk factor. Rarely we see Cowden syndrome, where women have hematoma formation at the age of 20, 30.
And coming closer to our own specialty, any nulliparity or...
nulliparity. So I say no uterus is spared. If you're nullipara, you have endometrial cancer.
Yeah,
if you're grandipara, you have cervical cancer. Women are not spared anyway. So these are the factors I would be looking for when I'm looking at. So these are
what about any protective factors?
Protective factors, obviously weight, keeping your weight intact, and having more number of.
I mean, like in the history, if a patient has been on OCs,
or we have put in a Mirena. So that I always recommend the Mirena for patients who have got a dysfunctional bleeding.
Progesterone acts against the estrogen effects, and so that
works as a protection in women who have had polyps before.
So is there any possibility of universal screening for these cancers?
No, there isn't. There are no tumor markers which have been found out, which have been.
Yeah, so there's actually no role for, because they're not cost effective. However, in high risk patients whom we have already mentioned, who are symptomatic, we can do it at regular intervals. Like if they have been on HRT or then we need to, anyway, they will be under screening, or anybody who's been on unopposed estrogens or who's been taking OTC, hormones. So those people you can think of doing a screening, but otherwise there's no role for universal screening. So what would we do to confirm the diagnosis?
Confirmation of diagnosis basically involves histopathological diagnosis. That would be either doing a pipelle biopsy in the OPD or doing a hysteroscopic directed biopsy.
Yeah, so in fact, a negative pipelle would also necessitate a hysteroscopy. But anyway, we want to discuss the next case as well. So any thought on this? Any role of tumor markers in C. endometrium?
So we say that HEV, human epithelial factor.
Dr. Jayashree, your audio is a little.
Can you hear me now? Yeah.
Yeah.
So CA125 and HEV are two markers which can be used for CA endometrium. Combination has showed a sensitivity of 73% higher than either marker alone, but CA125 is very non-specific. But HEV has a sensitivity of around 55%. I have personally not used it. I researched it when I
HEV is the new kid on the block, which is much more specific for CA endometrium. We are doing a few studies even at our college, and it is found to be promising. So let's see how it rolls out. Okay, so we'll move on to the third case. Dr. Vani, would you take this?
Thank you, ma'am.
45-year-old Mrs. Y who has come to you with complaints of postcoital bleeding for the last 6 months. So what are the important points you would elicit in her history?
I'll elicit a detailed history of the severity of the bleeding she is having, any associated symptoms like intermenstrual bleeding or any foul-smelling discharge, which may be blood stain. And the most common causes of postcoital bleeding in a 45-year-old female may be a cervical erosion, maybe a polyp or ectropion, and then cervical cancer. So if I want to rule out cervical cancer, then the pelvic pain, if she's having, which is suggestive of involvement of the uterosacral ligaments.
Yeah. What we are now basically talking is to focus on CA cervix. So what is the risk of patients with postmenopausal bleeding who are at risk of CA cervix?
It is usually less than 5% in postmenopausal bleeding, the risk of CA cervix and CIN, and the atrophic endometrium, as we have discussed, is the most common cause of postmenopausal bleeding.
Yeah, but then CA cervix is also a cause of perimenopausal bleeding. At least. So we must definitely direct our. So this patient has come to you with a 3x2 coliform like necrotic growth over the anterior lip of the cervix, and both parametria are free. So now, how will you proceed?
So I will take a biopsy. The biopsy should include both the normal tissue. It is a punch biopsy because the growth is visible on the cervix. So it should be deep enough to take the stroma as well. Yeah. And not only the necrotic tissue should be included.
Since we are running short of time, the biopsy report comes as non-keratinizing, moderately differentiated CA. So.
Okay. So then the patient should be clinically staged and to look for the involvement of the parametrium or the lymph nodes. And
so is imaging necessary for all cases, and what is the optimum modality that you would do?
The optimum modality for parametrial thickening and parametrial involvement and the size of the tumor is MRI. Yeah. And for the nodal status, it is usually, according to the figure, the latest classification, the CT scan or PET scan is used to assess the lymph node status.
So that is basically the difference. And then if we do find the lymph nodes, we upstage the disease as well.
We upstage the disease, and we do not go for the surgery of the patient. We directly go for chemoradiation or radiation therapy for the patient.
So that's a huge difference from the old figure.
Earlier class, yeah.
So what would be your indications for doing an EUA in this patient?
If you are not able to clinically assess the patient perfectly about the stage of the disease, or patient is very uncooperative, or you want to do, and patient is uncooperative, you want to do colposcopy or cystoscopy, then it becomes the indication for examination under anesthesia. Basically, you want to stage perfectly so as to impart the correct mode of treatment.
Then, so basically it depends on the treatment. I mean, the modality will define your method of treatment as well. Now, I think we'll skip this because we're running short of time. Dr. Shiva, would you like to take on this? What are the various types of hysterectomies, and is there a role of MIS for surgical management of CA cervix? Dr. Shiva, are you there? Dr. Vaishali?
I don't think Dr. Shiba has joined in.
She hasn't, sir? Okay. So then Dr. Jayashree or Dr. Vani, one of you can take on this.
So that the radical hysterectomy is classified as into 5 classes according to Piver-Ritledge-Smith classification. The type 1 is extrafacial hysterectomy. And regarding the role of minimal invasive surgery, we are doing both minimal invasive as well as robotic. But the largest trial, the LAC trial, says that it has got more recurrence rate as compared to the open radical
hysterectomy. There's almost a
hysterectomy.
difference of 10%, which is a very significant percentage. So right now, I think as the rules stand, I mean, there is a definite what do I say, difference if you do an open.
Open radical hysterectomy is considered more, I mean,
so
successful nowadays.
Discuss the adjuvant therapy and so we'll just go to because we're running short of time, and Dr. Biswas said that I should stick to time. So we've got just 2-3 minutes left. So we'll just do a brief recap. So one of the most important things in any case who comes with postmenopausal bleeding or perimenopausal bleeding is that we have to take a very detailed history with special reference to any HRT or any medications that she's been on. If I mean, she may just be a case of abnormal uterine bleeding, so you have to do an endometrial biopsy, which may just show you hyperplasia with or without atypia. So this is another common finding that we get on, so Dr. Payal, would you like to, what would be the treatment in a patient perimenopausal who's come to you with hyperplasia?
Well, it depends on whether the patient has hyperplasia with or without atypia. Hyperplasia without atypia, the chances of going on to malignancy are pretty low, as low as 5% over.
Now the classification has changed. Earlier we used to call simple complex without it. Now it's
with or without atypia.
Without atypia. So that's one point that we have to keep in mind. And if it continues, that is another point that I want to make, that if the patient comes to you repeatedly and your histopath does not show, but she is having postmenopausal bleeding repeatedly, then you may be in line to advise her hysterectomy. So these are the various other causes which we should not miss out on. I just listed them because most of them we have discussed. Decubitus ulcer we had not mentioned. And these are the points that we should keep in mind whenever we are examining or seeing a patient with perimenopausal bleeding. So there is very little role for screening. A detailed history and examination is extremely important, as we just mentioned. Investigations we have carried on. The rest, the definitive diagnosis, the gold standard remains hysteroscopy with a hysteroscopy directed biopsy or a biopsy without hysteroscopy. The treatment will depend on the cause, and we have tried to cover most of the important ones. The rest we will not be able to do in such a limited time. But this is, like I just said, this is if repeatedly you get a negative biopsy, but the patient is continuing to be symptomatic, we can consider hysterectomy. Because even the best investigations that we have available are only 98 to 99% accurate. So I think we have stuck to the time. It's exactly 4:30, and thank you. Thank you very much to all the panelists. I mean, I leave it to the organizers to see whether we are allowed to take questions. If there is anything, then we'll be glad to take them on.
Thank you very much, dear Menon.
I think the chairpersons can take on from here.
I congratulate Dr. Aruna. You have finished the panel right in time, and very nicely you have to start and how to take the history and all. So if anyone has any questions, can we take it? Yes.
I just wanted to make one observation.
Yes, ma'am.
Yeah. See, we get a lot of patients with postmenopausal bleeding, and more now than we were getting earlier.
Yes.
Similarly, we are now seeing many more cases with endometrial polyps. We get a lot of ultrasound reports that give us, endometrial hyperplasia as reported. Now, that is where the catch-22 is, because not all these readings of endometrial hyperplasia are really very correct. It is very important to have a good ultrasonologist, one whom you can rely upon to measure the thickness of the endometrium, because very often we have with reports which are reporting 13, 17 millimeters, and you go in, you do a hysto-DNC, and when you put in the scope, you find a absolutely atrophic endometrium. So one should be very, very careful to confirm that the endometrial thickness is indeed what it is stated to be on one ultrasound. So I would say that, you may have to take 2 ultrasounds into consideration instead of just 1 ultrasound.
Ma'am, I would like to say, I think the best
That's
thing
what
is
I had to
do your own ultrasounds. If you the more of ultrasounds you do, and there's nothing better than doing your own transvaginal ultrasounds. I feel it's a third hand that you have.
I agree, but in every setup that's not possible, plus different departments and things like that.
That is there.
But yes, this does give us a bit of a problem. And then another thing which I have noticed is that we are getting very many more ladies who are menopausal and sexually active.
That's right, ma'am.
So sometimes, hello?
Am
I audible?
Yeah, you're audible.
So I have had a few cases of, kind of traumatic injuries, which are post-coital in post-menopausal women.
Yes,
so then you have to advise them to use a HRT so that the vaginal mucosa is more supple and sex doesn't cause trauma.
That's very true.
Those are
Very
the 2 things
important
I wanted
point.
to say.
And one more thing we didn't mention is SIS, which is also a very important modality, because a lot of polyps can be delineated by doing an SIS. Actually, there isn't enough time to completely do the entire battery, but I think we've managed to cover most of it. I'll leave to
Yes,
on
it is.
behalf
In
of
fact,
the
SIS very important.
on behalf of
Just
the
a point,
organizing
because-
committee here,
Sir.
I thank all the panelists and moderator and the chairpersons who have conducted this session excellently. Thank you so much, all of you. So with this, we would like to go over to the next session. So the next session is of the keynote lectures. It's a session which we are all also looking forward to. For this session, I invite our chairpersons, Dr. P.K. Jhulka, who is the Senior Director, Medical Oncology at the Max Institute of Cancer Care at Lajpat Nagar, New Delhi. Dr. Rupinder Sekho, who is a Senior Consultant and Chief Gynecologic Oncology at the Rajiv Gandhi Cancer Institute, Rohini, Delhi. And Dr. Sapna Nangia, Senior Consultant, Radiation Oncology, Lead, Head and Neck, Breast, Gynae Cancer at the Apollo Proton Cancer Center, Chennai. I hand over the session to our esteemed chairpersons. I request them to invite the first speaker.
Good afternoon. I think the first speaker is Dr. T.P. Sahu, whom everybody knows as a leading medical oncologist, and he's in the Silver Line Hospital in Bhopal. He's practicing, and an excellent medical oncologist known all over India, not only India, but outside India also. And he shall be talking on role of immunotherapy and targeted therapy in gynecological malignancies. This is a very important topic because day in and day out we discuss these are cold tumors or hot tumors where immunotherapy may act or not. Then the targeted therapy coming as PARP inhibitors coming in more and more, and many new drugs are coming up, and the role of antibody drug conjugates and the new agents. So I would request Dr. T.P. Sahu to continue his lecture. This is a key lecture.
Thank you. Can someone allow me to share my screen, please?
Yes, sir. Now you can see, sir.
Yeah, thank you. Okay. I think I'm visible and the slides is visible. I'm audible. Yeah.
Yes, sir.
Yeah, thank you, Professor Julka. Thank you, sir. It's a long time since we met physically.
Yes.
It's very nice to see you virtually.
Yes.
And thank you, organizers, for giving the invite. But I should be very fair and honest on the upfront that this was something that Dr. Purvesh Parikh had to take, and because of some personal reasons, he could not. And I should make it very clear at the start, it's just not possible to fit in the shoes of someone like Dr. Purvesh, especially a person who has taught me medical oncology and who's a mentor, and if I can call him a friend. But I will try to do a job, whatever has been given to me in the next 15 to 20 minutes. And I'm going to speak on the role of immunotherapy and targeted therapy in gynec malignancies. So the outline of the talk will be, I'll first touch on immunotherapy, that's on endometrial cancer, where that's the most robust data. Then the ovarian cancer, then cervical cancer. Let's see what the data is all about in these cancers. Then we are going to go to BRCA and the PARP inhibitors, the real in thing, the buzz area, that's what it is. I will just also, I cannot just finish the talk without touching upon bevacizumab in ovarian cancer. Does it have a role today, and where we should be fitting in Bev, because it was a big hit around a decade back. And how can we forget the hormonal therapy, the old hormonal therapy which we have been practicing, and this is a target therapy which was one of the first target therapy in gynec cancers, but still is it relevant in 2021? So with that, let's come to endometrial cancer. And the stage for endometrial cancer, it has been chemotherapy, and something like chemotherapy for the past 2 to 3 decades.
This is clashing with the mic sharing.
So till we got something in the last 3 to 4 years. So the thing was that this is the Cochrane meta-analysis, which really told few years back that the intensive chemotherapy did improve a DFS and OS survival. There was no significant difference between different doublet combination, but mind you, they did not include the data from the GOG 209. And the GOG 209 was a triplet versus a doublet. It included doxorubicin in addition to pacli and platinum. It did not do much except for it was a non-inferior regimen. The doublet was equal probably with lesser toxicity. So the hype around the triplets in endometrial carcinoma went out, and paclitaxel carboplatin has since been a gold standard in metastatic and even in the curable, operable endometrial cancer wherever chemotherapy is indicated. So now we move on and come to the 2021. What should we be doing? Is it just a routine histopath examination? Is it fine? Is it good enough? Or what should we do? The additional test which I feel we should be doing at baseline should be a ERPR, and if possible, a HER2/neu definitely. MSI, a microsatellite instability by IHC/PCR would be something which I'll be looking at least not in the adjuvant, but at least in the metastatic setting. PDL1, is it of significance? We'll come to know in a minute. But the most important buzzword, the area has been very hot, is around the NGS. There has been multiple papers in endometrial carcinoma looking at the 12 gene panel NGS, where they have divided the tumors into 4 categories, which I'm going to come in the next slide. And that really differentiates the type of the prognosis. Rather than the predictive value, it's more of a prognostic value. And the tumor mutational burden, is there a role today? What is the data? And what should we be doing with the TNB? Because the data for lung cancer is still everywhere there. Melanoma is a little more robust, but is there enough data for endometrial cancer? Just if you look at the NGS and look at the 4 subtypes that happens, the most important, that is around 10 to 15% of patients of endometrial carcinoma come up to the pole variety, which is that they have the DNA polymerase epsilon that is there. So that is where it is a good prognostic marker. They are very responsive to immune checkpoint inhibitors, and they rarely metastasize. They are one of the better prognostic types. The second type would be MSI high, that is where they are responsive to immuno-oncological drugs. And then we come down, if these 2 are negative, like if you see, if there's a sample, they will look at the pole mutation, then we look at the MSI or the MMR, the deficient or proficient the tumor is. If that both are negative, then you look at the P53. If there's a P53 high, then you have a copy number high subgroup, and if the P53 is low, you have a copy number low. And what really happens is they've divided the 3-4 types, and we look at it, this is the pole variety, which is the highest number of mutations. That's why they're very responsive to immuno-oncology drugs. Then the MSI is somewhere here. Can someone mute themselves? There's a lot of background noise. I'm sorry for that. So if you come down again to the organizers, can you do something? So, so if you come down to the prognostic criteria, and if you see how the curves divide themselves, and the blue bold line is the copy number high. So where there's a P53 is high, they do really poor, and the pole which is there up there, and the progression, disease-free survival, and the OS is the best among that, followed by the MSI high, followed by the copy number low, and then the copy number high. So basically what we're moving towards is a molecular classification of the endometrial carcinoma, and probably we can prognosticate our patient in a better way. Now coming to immunotherapy, its role, if you look at it and look at how they work, the PD-L1, they bind to PD and PD-1, and this is why they inhibits the T cell killing of the tumor cells. What this immune oncology checkpoint inhibitors does is they block this binding, and that is why it allows the T cell killing of the tumor cells. There are multiple drugs. We have PD-1 blockers like nivolumab, pembrolizumab. We have avelumab and durva, which is a PD-L1 blocker. We also have CTLA4 inhibitors like the ipilimumab and the tremelimumab. So there are multiple areas how we can target and block this interaction between the PD-1 and PD-L1. Now coming to the endometrial cancer, the data is from a divergent cohort actually. If you look at the keynote, there is a publication which looked at the pooled analysis from the keynote. There are 5 keynote trials. The most talked about trial in the initial part is the keynote 028. And if you look at the keynote 028, it actually divided the patients in endometrial carcinoma in view of the PD-L1 expression. And they found that approximately 13% had a partial response and 13% had a stable disease. The number of patients were 34. It's not a huge number actually. But when they retrospectively analyzed it as per the MSI, and when the MSI high was looked at, the response rate was around 50% with a CR of 7%. And the duration was prolonged, and the duration was also sustained for approximately 22 months in some patients, and 78% had a response which lasted beyond 6 months. This was the initial data we showed that if you want to target the immune checkpoints in endometrial carcinoma, probably MSI is the way to go ahead. And then came the keynote 158, a large trial, which had 233 patients, and they looked at multiple tumor subtypes, but looking at gynec, around 20% were endometrial, around 6% were ovarian, and cervical was around 2.5%. What it had in this keynote 158 was, they had a median PFS of 4.1. In any immune checkpoint inhibitor trial, the median PFS is not that good. But if you look at the OS was around 24 months. And that is something that was never seen before with the chemotherapy drugs. And the most important is patients who had a response, the chances of ongoing the response was good. Those who responded, the tail was quite long. And if you look at the two types, if you can compare the endometrial and ovarian, and look at it, the median PFS, what it is around 26 months in the endometrial cancer, and it was very poor of around 2.3 months. That's where it was for the ovarian cancer. And the toxicity of immune checkpoint, just to give one pointer, if someone is requiring immunosuppressive agents or a high dose of steroids, that's where we do not want to use immune checkpoint. Otherwise, after 5 to 6 years of using immune checkpoint, all of us know the toxicity which are as per the duration. Some are very acute within 1 month, some are delayed toxicity within 3 months, but you have to check and look at any new thing that happens when you're giving immune checkpoint inhibitors. We should be very, very careful. The next buzz thing came is lenvatinib and pembro. And it happened that the non-MSI high, you spoke of the MSI high. If you look at the non-MSI high, this was something that the combination of lenvatinib at 20 milligrams and the pembrolizumab at 200 milligrams once in 3 weeks, it did produce a response rates of around 35% and a stability of disease around 47. The total put together, it was approximately 80 to 85% stability response, which happened at least a stable disease, and the progression was only 10%. So, again sustained it responses. The same thing it is showing here. So coming to that, what is the take home for this part? Lenvatinib at 20 and pembro 200 milligrams once in 3 weeks was granted accelerated approval for the treatment of patients in advanced endometrial carcinoma that is not MSI high. For the MSI high, you anyway have the disease, the only single agent immune checkpoint inhibitors. Just to put forward the tumor mutational burden, it was a cutoff of 10 megabases. And they found that if you have a high tumor mutational burden of more than 10 versus less than 10, the response rates were higher. So you did have a more response rate if you had a more higher tumor mutational burden. It was seen across all gynec malignancies. But the duration of response was also longer, but it did not translate into a significant overall survival. That is why should we be using a tumor mutational burden as of now in gynec oncology? I don't think the time is ripe enough. But yes, if the patients start to respond, irrespective of the TNB, they do continue to respond. Now, coming to the other gynec malignancies, ovarian cancer, I don't think it is a very great area of discussion. The responses have been very shunted. It's around 10 to 15%. Compared with the endometrial carcinoma, it's around 50 to 80%, depending upon the regimen which you want to use. Even the combination of IO has not been that great. And you come down to combination of chemo and immunotherapy in ovarian, also it is not that significant except for one single small trial. We have tried to combine anti-angiogenic BEV with immuno. We have also tried to combine PARP inhibitor with immuno, although the preclinical data is good, but I don't think that is much data that is going on and it's still we are some years away from getting these approvals in the non-endometrial cancers. Cervical cancer, the story is nearly the same. So the first part of my talk on immunotherapy drugs, immune checkpoint inhibitors, chemotherapy still remains the standard of care in advanced gynec cancers. Immunotherapy is an evolving field. In endometrial cancer, in failed one line of chemotherapy at least, or failed the standard drugs, if MSI high, you could go for single agent pembrolizumab. In MSI stable, lenvatinib with immune checkpoint inhibitor is the way to go. And in others, in MSI high, after having failed all approved means in ovarian and in cervical cancers. There's one more thing that's happening over a cancer. And this is the BRCA gene. And this is where the PARP inhibitors have really made the big push. And the Angelina Jolie, which we saw the effect happen in breast cancer, but the major effect, what we see in oncology has happened with the gynec cancer. We know how they act. They basically, the pair of DNA doublet strands are affected. And that's why the PARP inhibitors, they mainly are effective in the platinum sensitive. I'm going to skip these two slides and come down to the main important thing. The PARP inhibitors, if they have a BRCA mutation, these patients do better than those who do not have a BRCA mutation. But how do we test? Should we be testing for a germline or we should do a somatic or both? You can do it either way, but the more thing is that people do a germline first, and if they fail, then they get the tumor tissue to get the additional 5% for the somatic. You should do it at baseline. Probably the mucinous variety of ovarian cancer is one variety where you might not do the BRCA because it is nearly 0% to 1%. Other than that, every ovarian cancer should be doing this at baseline. NGS should be done, but you also should be doing the MLPA. That's very, very important because the large genomic rearrangements of 2 to 3% are lost if you do only NGS. And do we test for HRD? Yes, I think we should be doing for test HRD because there is a benefit of PARPs in the BRCA negative, HRD positive. And that is where the two subgroups, if there's a BRCA mutation positive or HRD positive, that are the two subgroups where the PARPs really work. Where should we use it? You can use it in first line. The approval has come. You can use it in second line. You can look up Rucaparib drug. It is approved in third line. So basically, the concept is earlier the better. If you have not used in first line, try to use it in second line. Now let's go to the last 2 to 3 slides. Now to something. Is there something that have been there for a long time, and is it worth the cost in ovarian cancer? The thing is bevacizumab. It's costly. It has been there for more than a decade. Where would I use it? I would probably use it in a case where the surgeon has suboptimally cytoreduced, or it's a stage 4 ovarian cancer. That is where the role of bevacizumab really comes in. Is the longer duration beneficial than 15 cycles? No, I don't think there is data to that effect. So the bevacizumab in upfront, I told about the indication in recurrent disease, in platinum sensitive and platinum insensitive, both ways has been tried with chemo. It has shown its superiority. And last slide, it's very, very important. It's not always cost. Have we forgotten the hormone therapy? And look at this endometrial cancer, a systemic review, and look at this beautiful article published last year. We have data that you can use tamoxifen and other SERMs, and the response rates would be low. But if you look at it, it is usually the bigger clinical benefit, because after failing 1 to 2 lines of chemotherapy, if there is stability of disease, I'd be very happy with that. Even you can use a combination like progestin, tamoxifen. You can use chemo and hormone. You can even use the hormone and mTOR. The benefit is still there. Is there a cutoff point? No. But one thing is there, if you have a ER positive, basically done at baseline, that is where you should be using a hormone therapy, specifically in endometrial cancers, after you have failed the first line chemotherapy options. So my last slide. What is the take home message 2 for mine? BRCA gene testing, I feel it should be done a diagnosis for all ovarian cancers, except the mucinous variety. That's where you may not do it. PARP inhibitors, a very important drug in the armamentarium. You just cannot miss it now. BEV in the high-risk patient and definitely a relapse. Hormone therapy is still a valid option in endometrial cancer. It is a cheap option and we should not be forgetting this option. So with that, time is also up and I have also completed my talk. Again, thank you organizers for giving me the opportunity, and I hope I could deliver some of the things which you expected from Dr. Purvish. Thank you organizers.
Dr. Julka, you're muted.
Ma'am, Dr. Sapna Nagia, I think you need to introduce the next speaker, please.
Yes. Oh, actually, I was waiting for Dr. Julka. Perhaps he had some questions for Dr. Sahu.
Just one or two questions I thought we could have from Dr. Sahu. Anybody would like to ask any question? Then I would request Dr. Sapna to introduce the next speaker.
Thank you, Charu, for inviting me for this session, as well as for putting together this wonderful program. It's my pleasure to invite Dr. Eric Leung for the next talk on the role of SBRT in gynecological cancers. Dr. Leung is Associate Professor in Department of Radiation Oncology and the Gynae Radiation Oncology Lead at the Odette Cancer Center, Sunnybrook Health Services at the University of Toronto. And amongst his achievements are that he's the co-chair of the Canadian Cervix Trials Group and the National Cancer Institute Gynecological Cancer Screenings Committee Task Force, as well as the NRG Oncology Cervix Core Committee. So we're looking forward to hearing Dr. Leung's opinion on SBRT in gynecological cancers.
Thank you very much for that introduction, and thank you so much for the invitation to present at this conference. The talks have been very interesting, and I think the discussion has been exciting, and really appreciate to be a part of this. If I could share my screen, I think everyone can see this now.
Yes, we can see your screen, Dr. Leung.
Great. So I'm going to be speaking on stereotactic ablative radiotherapy and hypofractionation in gynecological cancers. I don't have any disclosures. The objectives is to discuss a role of SABR, or stereotactic ablative radiotherapy in GYN cancers, oligometastases in SABR, SABR for primary boost for radiation, and the setting of reirradiation in patients with pelvic recurrences. So this audience knows the challenges of locally advanced gynecological cancers. These patients present with morbidity such as symptoms of bleeding, discharge, pain, obstruction with this lady who had a large stage 4A cervical cancer. And it's challenging for the treating physician as the treatments we can offer in radiation may pose toxicities given central location of these tumors close to the bladder, bowel, and rectum. We know that in GYN radiation oncology, we have advancement in techniques such as VMAT or IMRT to conform our radiation dose. This is becoming more and more standard in our treatments. Interstitial brachytherapy, MR-guided, CT-guided brachytherapy has really advanced our field, so we can conform the dose of radiation with high-level techniques. And here's a picture of the Venezia template that we use at Sunnybrook, where we can apply intrauterine tandems and multiple interstitial needles to really conform and achieve high ablative doses to the central areas. But one of the questions is that, we have brachytherapy that is advanced, external beam radiation, but the role of SABR has not really been well established in gynecological cancers. And so we're going to discuss the advancing techniques and how is this possible to really advance SABR and what the role of SABR is in GYN cancers. So we were interested in this topic a few years ago in 2016. Dr. Lucas Mendez, who now works at Western University in Ontario, was a fellow with us and performed a systematic review. And he looked at the role of SABR in the literature and found over 30 publications on SABR and GYN cancers. And there's 6 indications that he found that were 5 indications that were most common: cervical cancer boost, uterine cancer boost, pelvic nodal radiation, adjuvant radiation to the vagina, and salvage non-nodal recurrences or central recurrences. But the most common was the nodal SABR, being almost 200 patients in these studies being treated with this wide variety of doses, local control rates, and toxicity, but those seem to be very reasonable. But these are mostly retrospective studies. We also looked at this through a survey, and we found that in a survey of 11 radiation oncologists internationally that had expertise in SABR and gynecological cancers, many of the different practices and protocols were varied in SABR and dose constraints as well. But what we found was that most recommended SABR in the setting of recurrent nodal or oligometastatic disease or recurrent primary disease. So those two seem to be an important indication for SABR. Although the respondents did at times consider SABR for a primary boost, it was felt strongly that SABR would be contraindication if brachytherapy is available or not contraindication in patients. So those are the themes of our topic. So we'll start off with oligometastatic disease. And in oligometastatic disease, many of us know the SABR COMET trial, which is a phase 2 randomized trial from Dr. David Palma at Western University. This was a randomized trial between patients that had oligometastatic disease versus a standard of care treatment. So that the patients had SABR showed an overall survival benefit. And this has really been the standing trademark in the advancement of SABR in oligometastatic cancers. But one of the things that we have to notice is that only 2 of those patients in that trial had gynecological cancers. So when you look at the studies, there are a few that look at primarily oligometastatic disease and gynae SABR. One from Dr. Kunos, which is well known, which is a phase 2 trial using the CyberKnife technique. There was 50 patients with recurrent GYN cancers, less than 4 sites of metastases, median age is 66. And there was a wide variety of different tumor sites ranging from ovarian, uterine, cervix, vulva. Many of them had prior chemo, and the dose they used was 24 gray in 3 fractions. What Dr. Kunos found was that in the median follow-up of 15 months, there was very good local control. They didn't find any local relapses in the SBRT targets. The progression-free survival was almost 8 months with an overall survival of 20 months and very few grades 3 toxicities. If we note the sites of the SABR targets, most of them were indeed pelvic and periaortic lymph nodes. Another study that has looked at disease-specific gynecological cancers in SABR is this one from the Korean Radiation Oncology Group. And this was a prospective study, which was interesting, with 85 patients enrolled. And these were patients that were treated aggressively and definitively for their primary sites, but did have oligometastatic disease. And they used a dose of 39 gray in 3 fractions to all the sites. And with a median follow-up of 20 months, they followed these patients. And what they found was they had a fairly reasonable disease progression-free survival of 42% and 34% at 2 and 5 years. Very few grade 3 toxicities. Most of these patients, again, were lymph node metastases. There were 3 local central recurrences in the thorax and 8 other organs as well. We recently conducted a multi-institutional study between Sunnybrook and some partner centers in the United States. And so with 3 centers, we had 144 patients, 206 lesions. Patients range from mostly uterine cancer to ovary, cervix, and vagina. And most of the lesions were, again, pelvic and periodic lymph nodes. SABR dose ranged from 20 to 60 gray. The median was 40 in 2 to 5 fractions. So you can see there's a wide variety of doses. And what we found was the local control was reasonable at 1 year, 73 and 47% at 2 years. Overall survival was similar, and patients tolerated this well. Many of the patients had salvage systemic chemotherapy, and on multivariable analysis, it showed that the higher dose of radiation or biological effective dose of radiation seemed to be associated with local control of the disease. My colleague, Dr. Donovan, who really led this work, will be presenting this at the upcoming ASTRO Radiation Conference in October. And finally, with the emerging trials, there is now a systematic review on oligometastatic disease and stereotactic radiation. And this has shown as well a variety of tumors with metastatic lesions, mostly treated in abdominal pelvis with acceptable grade 3 toxicities. In terms of dose constraints from our survey, we found a significantly varying dose constraints per institution. There's only a few common published constraints that the group felt to be established, and this is the AAPM Task Group 101 by Stanley Benedict. And this shows many of the constraints that we would use for the bowel, bladder, and rectum. But it's noted that depending on the clinical scenario, the institutional guidelines and techniques, many of these can obviously vary. But at least the AAPM Task Group has a starting point with those constraints as well. This is a patient that we treated with endometrial cancer recurrence. And you can see that we prescribed a dose of 30 gray and 5 fractions, 35 and 5 fractions. And we limited the small bowel Dmax to 36, which is within the AAPM task force recommendations. The next indication I'd like to introduce is the SABR boost. So as you can see from our systematic review in 2016, that was another common indication, boosting the cervix. But we know for locally advanced cervical cancer patients, we treat this with external beam radiation and brachytherapy. And brachytherapy is certainly a mainstay of our treatment. There has been studies by Dr. Hahn, a colleague of ours, and Dr. Gill, which have shown that looking at SEER and national cancer databases, that those patients that have not had brachytherapy had an inferior overall survival. The Gill paper actually specifically focuses on SABR, and patients over the years in the database that was treated with SBRT or SABR compared to brachytherapy, again, had a decreased survival when using external beam technique. So we know the importance of brachytherapy. This was also shown in vaginal cancer boost as well by Orton and Dr. Gaffney's group. When you look at the clinical systematic review in clinical oncology, yes, there were many studies that looked at SABR boost, but however, these were all largely retrospective. So one of the recent prospective trial is by Kevin Albuquerque at UT Southwestern. It's a phase 2 trial for patients that were medically unfit for brachytherapy. And we have to note that there's 15 patients. They had very large tumors, obviously, in this group, But this trial actually showed significant grade 3 toxicities, 26.7%, predominantly rectovaginal fistula. It's noted the dose that they tried to achieve was 28 gray and 4 fractions, which is a brachytherapy dose. And there was increased toxicity. They hypothesized likely due to the larger tumor. And you can see that their median rectal dose D2CC was 91 gray, which is higher than what we'd expect in brachytherapy. The other point in SABR for primary boost is the central motion of the tumors is important because we know that these tumors, these cervical cancer tumors, move between treatments and during treatments. So we need to account for that motion. And so in brachytherapy, we don't account for that motion, obviously, because the applicator is in place. So we have larger volumes to treat, and larger volumes means more toxicities as well. What we've tried to develop, if we were to treat a SABR boost, is a vaginal immobilizer to try to limit the amount of movement of the cervix or vagina. This was developed in-house by our lead physicist, Dr. Nance Ravi. Here's an example of a case that we treated for a patient with a recurrent uterine cancer. Using this vaginal immobilizer, this patient had severe cardiac comorbidities and was not deemed acceptable risk for spinal or general anesthesia by our anesthesiologist. So we treat her with a SABR with a vaginal immobilizer. We prescribed to 27, 5, and 5, but we tried to limit the bowel and rectum to 25 and 5 max dose. So in conclusion, SABR boost would, from the prospectus trials and the study by Dr. Albuquerque, we would recommend this only in patients that have a contraindication to brachytherapy. We would work hard to offer patients that are eligible to have a brachytherapy boost, as we know that affects their survival. If we were to treat with external beam radiation, typically at our center, we would not try to replicate the dose of brachytherapy, given the fact that we have larger volumes, is not as a conformal technique. And to safely achieve a treatment, we would need to limit the dose. A mobilization of the target is important as well. And finally, the last topic I'll discuss is reirradiation. This is a very challenging issue as patients that have reirradiations in the recurrences in the central pelvis have really limited options of treatment, especially if they have lateral disease that is not suitable for exoneration. With improving systemic treatment, we see longer systemic control. And so, you know, in our systematic review, we found that salvage non-nodal central recurrence that were treated with SABR in 57 of the patients in the systematic review. But it's noted the grade 3 or 4 toxicities were higher in this group. You can see at 19% as compared to the other groups. So reirradiation certainly affects the risk of toxicities, as you can see even from this systematic review. So what we have done at Sunnybrook is we typically try to treat these patients with interstitial brachytherapy if possible. And obviously, these are patients that have limited systemic disease, are fit for brachytherapy, as we feel that we can achieve conformal doses for patients with reirradiation in the central area. Our previous fellow, Dr. Hamid Razi, who now works in British Columbia, published on this technique. This is a patient who had a previous 45 and 25 for uterine cancer and had a central recurrence in the vagina, and we treated her with brachytherapy with interstitial techniques just to conform to the area of local recurrence. We published on this technique of the limited number of patients we have, and the median overall survival was 28 months. So we found that this technique does offer, number one, suitable palliation for central recurrences and does have a reasonable survival and local control of these patients. However, obviously not many of these patients have advanced disease in clinical scenarios, and brachytherapy may not be suitable in this case. And so we have treated patients with SABR. This is a patient with a recurrent grade 2 endometrial cancer after 5 years of external beam radiation. Given that it was 5 years and they only received 45 gray previously, we prescribed 30 gray and 5 fractions. Here's a patient who had recurrent cervical cancer with a large central recurrence. Previous pelvic radiation and brachytherapy over 6 years ago. In this patient, you can see we conformed the dose to the central and lateral area, but we prescribed to 25 and 5. The rationale of this dose was we felt that it's been 6 years, there may be a certain amount of repair. We have treated patients that have had full dose radiation and brachytherapy to 20 gray and 5 palliative in the past. We felt that with the SABR technique, 25 and 5 with 6 weeks, 6 years of treatment may be reasonable. And finally, we feel that our policy is when we consider reirradiation in these cases, we do calculate the cumulative organ at risk dose. If there's a short time interval between reirradiation treatments, we would limit the OARs to the standard dose constraints, not accounting for repair, obviously, because the short time interval. Yes, there are clinical scenarios that may be considered to increase the dose, for example, in patients that have large central tumor that is causing more morbidity, and the potential risk of toxicities would be outweighed by the morbidity of the tumor. There's no consensus on how much repair there is, as we know that there's limited data on bowel and rectal repair, but some consider a conservative estimate of 5 to 10% repair per year when calculating their cumulative doses. So in conclusion, GYN SABR is an emerging field. Using it for illegal metastases is also emerging. It's challenging when we're considering central disease radiation like a boost, and of course reirradiation. Further prospective studies are really warranted with clinical trials and collaborative studies. I'd like to thank my colleagues, Dr. Lucas Mendez and Alicia Donovan, who have really helped spearhead this work in Canada. Thank you.
Thank you, Dr. Leung. That was a wonderful talk.
Thank you.
It's very comprehensive. Are there any questions? Dr. Leung, in that case, I'd like to ask you about, your opinion about the Korean study and 39 gray and 3 fractions. I saw that your own prescriptions are a little more, I should say, conservative. So what do you think is safe? I mean, I would be very scared personally to do 39 in 3. And what is your view on the optimal dosage?
Yeah, that's a great question. You're correct, and it's a good observation that you notice. In our institution, most of our SABRs for the abdominal cavity is limited to 5 fractions. I think most of the data is 5 fractions. 3 fractions, personally, for us, we are a bit more conservative. That being said, I mean, when we did our survey, there are ranges from not only 5 down to 3, but some even down to 1 and 2. So I think that it's reasonable to consider 3 if your center has experience. There is more and more data, but I think it has to fit your own center's experience and technique in the end.
Right. Thank you. Thank you.
Thank you.
Any other questions from the audience, delegates? Thank you, Dr. Eric. Oh, I see that there is a question. What doses will be the Q? I'm sorry, I seem to have some issue reading the chat. Charu, go ahead.
Yeah.
And
Dr. Eric, I wanted to ask what cumulative doses will you accept for rectum and bladder in a re-radiation case?
Yeah, no, that's a great question. As I said, I mean, there's not a great answer to exactly what it would be, because it would probably depend on the clinical scenario. What we would start off with in a reirradiation setting in the central area is calculating those cumulative doses and using what we look at in brachytherapy, max doses, to the bladder and bowel in the previous Jack Estro constraints of like a 90 gray for bladder to the 75 to the rectum and bowel. We start off with that, obviously, but it's actually very difficult to achieve that when you're not using brachytherapy, when you're talking about D2CC maxes. So we start off with that, and as you see from one of the cases with the recurrent endometrial cancer who had previous 45 gray, I prescribed a 27, 5, and 5. We tried to limit that max dose to around 75. I think it achieved around 80. We felt it was acceptable because there's some repair. So I think a safe starting point is using the brachytherapy constraints. It's a little bit conservative because you're using external beam radiation. It's not possible to achieve it, but then you have to take into account repair in the clinical scenario. As you can see from the Albuquerque study, when they tried to do the brachytherapy doses, which is commendable because they're trying to mimic brachytherapy with SABR, the median dose of the rectum was 90 gray. It's not possible to achieve those. So I would, and in the end, there was fistulas and a lot of grade 3 toxicity. So I would be more conservative, knowing that we can achieve the same results.
Thank you.
Thank you very much. It was really very nice talking.
Thank you. Thank you very much.
Can we move on? Organizers?
Yeah, ma'am, please.
Okay, so thank you very much, Dr. Harith, Brigadier Manas, Biswas, and Kanika, Charu, and all for having me here. It is my proud privilege and pleasant duty to introduce the next speaker, who happens to be a personal friend for so many of us. So here we have Dr. Mario Laccio from New York, the Memorial Sloan Kettering Hospital. And he's the Fellowship Director, Gynecology Service, also Director of Minimal Access and Robotic Surgery Program in the Department of Surgery at MSKCC, New York. He is a tremendous number of achievements and awards. He's a US board certified gynecologic oncologist and a member of multiple national and international societies, as well as a member of multiple national committees. And we have had the pleasure of hosting him several times. He's done fantastic surgeries whenever he's come to India. He's received the Michael E. Burt Memorial Award for Clinical Excellence. And this award is given to the outstanding graduating fellow in the entire Department of Surgery. We are so happy to have you with us, Mario. And he's going to be talking to us on about fertility sparing surgery in endometrial cancer. The screen is all yours.
Oh, great. Thank you, Rupinder. Is this on? Can you see my screen?
Yeah, you can. I think if you can put it on slideshow.
Yep.
Yeah.
All right. Thank you, Rupinder. And sorry I can't be there in person. Do you see the slides itself?
Yeah, we do. Thank you.
We're good? All right. Okay, whatever. All right. So thank you for inviting me. And again, I'm sorry I couldn't be there in person with you guys today, but next one maybe. It's great to see some great friends, and hopefully we can have you here in New York again sometime soon. All right, so today I'm going to just speak about fertility preservation specific to women who've been diagnosed with endometrial cancer. These are my disclosures, none of which are really truly pertinent to this discussion. So at least in the United States, endometrial cancer happens with some frequency in women who are younger than 45, and also in the United States, at least, women are delaying the childbearing more and more to later ages for various reasons. So about 7%, maybe 10% of cancers of the endometrium are diagnosed in women who are less than 45. So, obviously, and who still want children. So who do we consider as candidates for fertility preservation? And we've been quite strict at our institution in many places, although I think there is some room for individualization if they don't meet these strict criteria. But the strict criteria have always been that they have to have a FIGO grade 1 endometrioid histology. We do not consider preservation of fertility for carcinosarcoma, serous grade 3 cancers, and such. Clear cell cancers, we also don't consider it. They have to have no myoinvasion, but obviously without taking the uterus out, we have to use other surrogates for assessing for myoinvasion. They have to have obviously no metastases. You need a compliant patient. You cannot have someone who will not follow up with the required follow-up biopsies and care. And, it's been, at least at our institution, that if you have no response by 12 months, you start to consider hysterectomy. That's not such a hard, fast rule, but it is something we start to talk to them if there's been no response by 12 months. And why do we have these criteria, and can we expand them a little bit? The first reason why we have this strict grade 1 no myoinvasion is really because of the concern of nodal metastases and spread. And really the only group that has reliably reported zero rates of lymph node metastasis, although there is no such thing as zero in life, but is really truly the grade 1 limited to endometrium cancers that have really truly zero risk, at least in GOG 33, which was a pathologic study assessing lymph node metastasis risks. So that's why we have chosen to be very strict with these cases. Also, the problem is that GOG 33 was based on final pathologic evaluation. And what we use now, since we don't have a hysterectomy, we can't have that specimen, we're using pre-op grading. And so that's why we have to be more strict, because, pre-op grading is not perfect. This is a study we did ourselves. And, if you look at those who had a pre-op 5.0 grade 1 endometrioid cancer reviewed by MSK pathology, that, 15 to 16% will be upgraded on final pathology to a grade 2 or 3, and occasional serous cancer will be diagnosed also. And if you look at actually the higher risk features of having a 1B grade 2 or 1B grade 3, you can see here that's 14 to 22% of these patients who had a pre-op grade alone biopsy can have higher risk cancer in the uterus. So, this is why we need to be very careful with these women, because these are curable cancers, of course. If you have if this is cancer in a background of atypical hyperplasia, the risk is less so, especially if you're very young, less than 40. So if you have really basically the super low grade, if you will, endometrial cancer in a background hyperplasia, in a very small series here from our institution, the risk of having a grade 2 tumor was 0. If you're over 40, again, there's a higher risk of upgrading of these tumors on final pathology, which means they may have these cancers in the uterus at the time you're trying to consider fertility preservation. Do you do office biopsy or DNC? I think for diagnosing cancer itself, office biopsies, endometrial biopsies, Pipel, whatever method you use, are acceptable and equivalent to diagnose cancer. When it comes to assessing the grade and correlating that with what's actually in the uterus on final pathology, DNC is better. As you can see here in our own institution here, those who had DNC, none were upgraded to a grade 3. Where some were office biopsy, but if you really, the overall upgrading is about half if you do a DNC. And if you look at risk groups, like the FIGO-based risk groups, the GOG-based risk groups, that's definitely much lower after a DNC being done and then the hysterectomy being performed. So that's why, at least for us, for endometrial cancer, for sure, this is not for hyperplasia, and office biopsy is probably sufficient, although it's not unreasonable to consider DNC. But for us, if someone's come to us with a grade 1 endometrial biopsy, we will do a DNC to confirm this. Now, how do you assess for myoinvasion? That's also tricky. There's no perfect test in the world to 100% correlate with final pathology. And if you look at different modalities, MRI, CT, or ultrasound, probably the worst one is CT scan. So that's not even a consideration for us. That really is bad at assessing myoinvasion. And it seems that MRI and a contrast MRI using receiver operator curves seems to have the best correlation with final pathologic depth of invasion. And if you look at a contrast enhanced MRI, it's much better in terms of sensitivity and specificity compared to ultrasound alone. Now, these modalities may not be available everywhere in the world, but I think if they are, and you have a choice, then you should do a contrast enhanced MRI. However, if you don't, an ultrasound by an expert ultrasonographer will be your next best choice. CT scan is of zero value for assessing invasion of the uterus. And this is what one of our, no, this is from a publication. This is what, contrast enhanced MRI will look like, where on the left here, you have evidence of superficial invasion, and here's of deep invasion. Now, we would not offer fertility preservation likely to either one of these cases. And when you look at the probability of MRI findings for deep myoinvasion, this is not for any, this is for predicting for deep, the negative, false negative rate is about 1%. So even If it says there is no deep invasion on MRI, you can still 1% of the time have deep invasion, and that false negative rate gets higher with the higher grade of tumor. So again, that's why, again, we have to try to really be careful with grade 1. That's the only case we truly consider fertility preservation. The other problem, though, is this: you can overcall deep invasion on MRI. So you might actually tell someone they can't save the fertility and be incorrect and take the uterus out, and there really wasn't the same myoinvasion that was seen or what you thought on pre-op imaging. So it's a very tricky field, and definitely it's difficult both ways, because if you take the uterus out and someone who wants children and there was less risk cancer in there, then it's can be just as devastating sometimes. Looking at a prospective study comparing transvaginal ultrasound and contrast to enhanced MRI. These are expert ultrasonographers, at least in the hands of expert ultrasonographers, for just looking at less than or more than 50% myoinvasion. This has nothing to do with just looking at any myoinvasion, because really we want no myoinvasion on imaging. It seems that if you have an expert ultrasonographer, they can do just as well as a contrast MRI. And that's okay if you have such a person in your institution and you do not have MRI. Look at pooled analyses of prospective studies comparing contrast versus just T2 weighted images for MRI. If you are using MRI, the best modality for assessing for any myoinvasion, which is what we care about when selecting patients for this, is a contrast enhanced MRI with the highest specificity and sensitivity. If you're looking for just deep myoinvasion, it probably doesn't matter, but we really want to make sure we're identifying cases that do not have myoinvasion at all. But it's not perfect. Positive predictive value is not great. So if you say that there is any myoinvasion, you take the uterus out, you'll be correct only 65% of the time. And if you say there is no myoinvasion, you're incorrect 15% of the time. So again, there's a lot of risks that you have to discuss with patients, and no imaging is perfect. So this is a long discussion with patients usually. The other thing you have to consider if you're preserving fertility is what's the risk of them having an ovarian malignancy at the same time, whether it be synchronous or metachronous. This is an older study, but there are other studies looking at coexisting ovarian malignancy in women with very similar findings. Bottom line is, if you have normal imaging of the adnexa, which is your MRI and or ultrasound, and you have intra findings that are normal, the risk of ovarian malignancy is about 5% if you look at them directly and they're normal, or about 9% if they're normal on imaging. And that ranges pretty much across all the studies. So anywhere from 5 to 9%, you have to let your patients know there may be a coexisting ovarian malignancy. Now, this is at the time of surgery, but if you save the ovaries on SEER data, the numbers change a little bit. And if you follow women with stage 1 endometrial cancer using our US SEER database, and look at what the rate is of finding endometrial cancer and follow up, and those who retained ovaries, it's actually quite low, a little bit lower than the numbers I showed you there, but it's not zero. So the 5 and 10 year incidence in women who preserved ovaries after endometrial cancer surgery is about 1% and 1.3% overall. The risk is actually higher in younger women, who are the ones who are preserving fertility on. It's 2 to 3%. So the bottom line is here, whatever the number may be, it's less than 10%, probably around the 2 to 5% range. But the most important message is you have to let them know that they do have a risk of developing an ovarian malignancy, either a synchronous or a met. This was one of the original sort of an literature review a long time ago from Dr. Ramirez, looking at the articles that have been published at that time for hormonal therapy. At that point, for endometrial cancer, there was only 81 patients published on. These were all grade 1 endometrioid adenocarcinomas. For some reason, some were postmenopausal. So this, guys, was not just for fertility sparing, just used looking at hormonal therapy. And I'm sure those 4 postmenopausal women had other contraindications. And if you look at response to back then to hormonal therapy, you actually about 75% of women with grade 1 endometrial cancer will respond to some hormone-based therapy. It's all progestational-based therapy. However, some of these women will recur, and we knew this back then, about 24% will recur. The median time to response has been up to has been 12 weeks. So that's why some people choose some of these time periods of 12 weeks, 6 months, whatever it might be. But you can see responses, at least back then, up to a year. And in those who recurred and want to still preserve fertility, you could retreat them with almost another 75% response rate at that point. we'll forget these slides. So since that time, people have tried to do prospective assessments of progestational therapy, but this is a rare situation, so there's smaller numbers. A phase 2 study looking at hydroxyprogesterone acetate was done. And what they showed is that the complete response rate in endometrial cancer is 55% versus 82% for hyperplasias. Atypical hyperplasias are much more reassuring, and they across the board have higher response rates. The partial response, there is partial responses, and this was at only a few weeks time. If they waited longer, you'd have even more complete responses possibly. And about 14% of women with endometrial cancer did not have a response at all and had no change. However, in these patients who some wanted to save their fertility and refused hysterectomy at the designated 26 weeks, those who had a PR beyond 26 weeks continued on hormonals, and some were able to achieve a complete response a few months later. So I think you also need to be very careful giving up too soon on these women who are very desirous of fertility. In endometrial cancer patients specifically, there is a recurrence rate that I mentioned, and you have to keep that in mind. The median progression-free interval for these women who recurred was about 35 months. And if you have anovulatory cycles, this seems to be a higher risk. You can retreat these women. Again, like I said before with the Ramiro study, 75% will get a CR again. These are high-risk cases, and one patient in this series developed carcinomatosis and died from endometrial cancer. So that's something you have to tell patients too. And that's why we push for hysterectomy once they are done with their childbearing, just to eliminate any risk at the end. A retrospective study from Korea, again, looking at different factors to predict for complete response. Again, having endometrial cancer, response rates in the 80% range of complete was great with both agents here. This is Megace and Provera. There really was no significant risk factor other than heavier patients tend to have lower response rates. Doesn't mean you can't do it, just means that you need to know that. And then if you look at other factors that might predict for recurrence after complete response, again, the heavier patients have a higher chance, which makes sense. Not quite sure why there's a difference for the different types of progestin, but those who go on to maintenance therapy, either birth control or continuing IUD, they have a lower recurrence rate also. And those who get pregnant, which makes sense because that pregnancy is a high progesterone. We'll skip there. So another phase 2 now looking at progestin plus metformin. Again, small series here, phase 2 study. They all went on progestin plus aspirin to prevent DVT. Once they had a response, they discontinued a low-dose birth control pill. And again, the complete response rate, adding metformin, was about 81%. Really not much better than what we've seen so far, to be honest with you. And again, there is a recurrence risk, even with this approach, and all the recurrences were in those who had endometrial cancers. So again, adding metformin does not seem to increase your response rate or risk of recurrence. Looking at IUD versus oral progestin versus cyclic, which is continuous, versus cyclic progestin. Now, this is just for hyperplasia, but it gives us some sense of whether we can do this. And really, between IUD and continuous oral progestin, there was no difference in sort of response rate with hyperplasia. The only one that seemed to have less response rate is if you give it cyclically. So we do not give cyclic progestins for women who have who desire fertility preservation. IUD here for hyperplasia endometrial cancer. Again, it just shows that if you can use an IUD as a progestin agent, and the hyperplasia cases again have the highest response rates, but in the MD Anderson series, some did progress. And then grade 1 and grade 2 seem to have similar complete response rates. So now there's some of us who will carefully also allow grade 2 patients to have fertility preservation to understand the risks. You can do hysteroscopic resection, but for time's sake, that doesn't add any additional benefit unless you see a localized lesion, and it doesn't seem to be any better than doing progestin therapy alone. The FEM trial recently published by Dr. Obermeyer, Dr. Janda is the first author. This was a prospective trial, women with CAH or grade 1 endometrial cancer, BMI of over 30. They all had, obviously no METs. They had to have no extrauterine disease. They did allow for women with MRI invasion up to 50%, which we don't usually consider. Anyhow, they all had an IUD and then were randomized. This is a phase 2, so it's still small, to either nothing more, weight loss, or metformin. And really, this is sort of the flow of patients. You can just realize how complex doing these studies is. And really, if you look at this, there really was no improved response by doing a weight loss regimen and or adding metformin. So we typically don't add metformin. We always encourage weight loss for other health reasons, of course, if they're heavy, but it really doesn't seem to alter the response rates, at least using an IUD. And again, looking at different variables here, the only thing that showed a higher response was in those who had hyperplasia versus cancer, which we've seen already. And now we always get afraid of women who have persistent endometrial cancer after the initial progestin therapy, but I guess with careful counseling, we have considered this, and this is a retrospective study that showed that in women who had persistent endometrial cancer at least 9 months after progestational therapy, who still strongly desire fertility, and I actually have a few of these patients who are going on many years, cautiously, that you can induce you can get a complete response rate in women who have persistent endometrial cancer at 9 months. So the point here, and this is a pretty 73% of women who had persistent cancer at 9 months actually were able to achieve a complete response with continued progestin therapy. It requires very close follow-up. I do a DNC on all these women every 3 months, especially if it's persistent. We definitely don't want to hurt anybody because there have been bad outcomes reported. We will skip this here now. And now the other important part when you take care of young women with endometrial cancer is that you need to check for Lynch syndrome. It's routine for us here at our institution. And there's some suggestion that those who have deficient MMR tend not to have responses to progestational therapy. It's a very small series here with only 6 with abnormal IHC, but we also counsel our women who have deficient MMR, which we check on their biopsies and offer impact testing, which is our genetic testing profile for women who are young with endometrial cancer. So we still will try it, but they need to know they may not respond as well. We'll skip this one. So we have a very specific criteria checklist that we use at our institution for women who are considering this. Now, these are checklists and these are guidelines. We will sometimes deviate slightly in an individual situation with careful counseling. And I can share these slides, of course, and it's hard for everyone to read all these things now. And this is kind of my approach, which again, which I use on every patient. I'm not going to be able to just go into detail for everything here, and I can share my slides again for everybody to have this for yourselves if you wish to use this as a general guide. And this is how I approach my women who have endometrial cancer. Now, my preferred starting progestin is either Megace, 80 twice a day, or to place an IUD. But you can use Provera, or you can just say you want to place the IUD, the Mirena. But it depends. It's a discussion with patients, and we discuss pluses and minuses. So we can forget this. So again, when you are also discussing fertility preservation, you have to remember there are other options for women who desire to have children. Some of these are medically easy, but financially difficult. And legally, there's issues, at least in the US, like for surrogacy. You can't get a surrogate in every state in the United States, which just doesn't make sense. And there's always adoption, of course. So thank you. I went over my time some, but I apologize. Thank you so much. I'm happy to take any questions or whatever you'd like to do.
That was an excellent disposition, Mario, as always. And I think we'll just, if organizers, can we just take a couple of questions? We see here in the chat box, we have Shalini who is asking, is hysteroscopy needed before considering fertility preservation? Do you just do a DNC, or would you do a hysteroscopy and a lab?
I'm not a big fan of hysteroscopy, but the answer is it depends. I don't think that hysteroscopy, if someone has a thin, homogeneous lining, I do not find hysteroscopy offers any value. Just a waste of time, increases your risk of perforation because you have to get a bigger scope in there. If I do hysteroscopies because I see on ultrasound or cellular infusion sonogram that there's a discrete lesion that I'm going to resect. So just to put a scope in to look, and then like a flexible scope just to look and then do a DNC, I've never understood that approach. I think that hysteroscopy makes sense if you're going to use the scope to direct your resection. So if there's sort of abnormal sort of a mass-like type thing in the fundus, I may put this, I would do hysteroscopy with a resectoscope and plan to resect the abnormal area. But again, if it's a homogeneous lining that's thickened with no abnormalities, otherwise to suggest polyps or such things like that, I just do a DNC. I don't think routine hysterectomy, I'm not an all or none kind of person. I don't think we should do everything for everybody and nothing for anybody. I think it's an individual decision. I think if you're going to consider using hysteroscopy, I think using a flexible hystoscope is a waste of time, to be honest. I know there's going to be differing opinions. That's my opinion. I do think if you see sort of focal lesion, that at that point, I plan for a rigid hysteroscope with resectoscopes. I will directly resect that area that's abnormal.
Oh, so you mean that you prefer to do an office hysteroscopy, if at all? You do not. We
don't even have office hysteroscopy at our practice.
Oh, is that so? So you mean whenever you do a hysteroscopy, you take the patient to the OR?
Like I said, if I'm going to do hysteroscopies, because I'm going to be resecting things.
Okay.
So office hysteroscopy to me doesn't really, whatever. It's my personal thing. I know there's lots of folks who are very in favor of it. So please just remember, this is my view on the world. But we don't even do it. Our patients who come to us, they all come with a diagnosis already because we're a referral center, right? So they already have endometrial cancer, office biopsies were done elsewhere. We get an MRI. If the MRI shows no focal abnormality, I don't see a reason to put a scope in there. Just do a DNC if they've had an office biopsy. That's my approach. And again, we see women who have breast cancer who have bleeding and abnormalities. If their lining is homogeneously thickened, I just do a DNC. If there's any focal abnormalities seen on ultrasound or MRI, then I plan for a resectoscope, operative hysteroscopy, not just a flexible scope. I don't know that helps much.
Okay, so there are a couple of more questions. I think we have one more question perhaps we can take. What is the role of double protection with oral progesterone and Mirena?
Yeah, we have used that. I would reserve that for those who are not having a response as much as you like. So I usually start with one or the other, not start with both, because then you don't know.
What is your preference?
So it depends.
And how do you determine which one of the two?
Yeah, that's a challenge a little bit. The downside with the oral progesterone is the weight gain pretty much, and some women talk about hair loss and bone aches, and it's a pill they have to take. Two pills they have to take twice a day. So that's the downside. But the upside is they have to put nothing inside the uterus. And when you put an IUD in, if you're doing DNCs, you'll have to occasionally replace it every time you do a DNC. So that's a cost to that, obviously. It's not really a concern because you're doing a DNC anyway. So that's what I do for endometrial cancer. I repeat DNCs. I don't do office biopsies for endometrial. For a hyperplasia, I will do an office biopsy. So it really depends talking to patients. For my heavier patients, I usually will counsel them more towards the IUD.
Okay.
For women of normal, whatever that is in the United States nowadays, of not so obese, I would say that I just talk to them, take a pill or we put this IUD inside. So we have been moving more towards IUD here, to be honest with you, but it's still an open discussion. And I can't say that one's better than the other. It's really a patient's. You put the IUD in, you don't have to worry about taking a pill. But you put the IUD in, you might get cramps from it. There's a slight risk of infection, I guess. And there's a risk of losing the IUD coming out and having to replace it every time you sample the endometrium. But that's a minor concern.
Yeah, thank you so much. Just one last question, which everybody seems to be asking, your views on ovarian preservation.
For when you do the hysterectomy? Endometrial cancer in general?
Yeah. Ovarian preservation when you are doing a hysterectomy for a hybrid endometrial cancer.
Yeah.
Do you take away the ovaries always? What is your criteria for leaving behind the ovaries?
So the short answer is no.
Is it BMI? Is it
no? The short answer is the short answer is we don't take it out. Obviously, so you have the postmenopausal female. That's not the question, right? That's easy. You take out the ovaries. It's in a premenopausal, less than 40, 45-year-old, do you take out ovaries? And we have not been routinely taking out the ovaries for endometrioid adenocarcinoma. We do recommend it for serous, for carcinosarcomas, for the higher risk histologies. But for endometrioid, if the ovaries look normal on imaging, and they look normal intra-op, and they're less than 45 for sure, we do give them the option of saving ovaries. And there's enough data now from the US saying that is safe. There is a risk of having ovarian disease detected in follow-up of about 2 to 4%, and they need to know that. But in those women, if you follow them, you can salvage or take that mass out at that time. So we do consider keeping the ovaries in women who are less than 45. Over 50, we tend to encourage removal of the ovaries, especially if they're menopausal. It's that between 45 to 50 range that we kind of struggle, and we will offer it and let them decide. But I have women in their 20s who have endometrial cancer, and we've taken, and those women, I almost tell them they should keep their ovaries.
Yeah, only thing is that patients with endometrial cancer and less than 45 years are few. Most of them are above that age group. And then there is one school of thought where they want to preserve the ovaries right to 65. So I think we'll go with what you're saying. Thank you so much. I think in the interest of time, though, there's so many more questions. Have you with us, Mario? Thanks a lot.
You're welcome.
I thank the organizers for having us here together.
Thank you. Thank you so much, all the esteemed speakers and the chairpersons. And since we are running a bit late behind the schedule, I would quickly move on to our next session, which is gray zones. So for the gray zones, we have a polling system. So I think everyone can sort of go into the polling booth by clicking on to a tab which is on the left lower side. Avinash, can we have that slide from where the delegates can enter into the polling session? So these are basically the areas where, you know, the evidence is not much or it is very rapidly evolving. So it is generally a gray zone where you will not find great answers. So there would be a pre-poll before the discussants and a post-poll after the discussants, and then there will be an expert opinion. So for the first question, I would like to invite Dr. Sharan Chaudhary. Who's a senior surgical oncologist at Max Institute of Cancer Care, Delhi. Over to you, Dr. Sharan Chaudhary.
Thank you very much. Good evening and a very warm welcome to all. So as mentioned, we first have poll before the presentation. Our first presentation on the gray zone is the role of sentinel lymph node in high-risk endometrial cancers. Are we ready? Well, the surgery of cancer is the surgery of lymph nodes. This was first stated by Lord Moynihan Leeds over a century ago, and it holds true even to this day. As surgical oncologists, we are obsessed with lymph nodes, and as we know that the survival in a cancer patient is to a large extent dependent on whether the nodes are involved or not, and if involved, how meticulously we surgically remove them. Unfortunately, a full lymphadenectomy will have a serious surgical risks and post-op morbidity, but a sentinel lymph node biopsy is an elegant alternative in early endometrial cancer. In high-risk cancers, can we forego a full lymphadenectomy and rely solely on sentinel lymph node? This remains the gray zone, and to address this gray zone, we are fortunate to have with us the presence of the experienced and eminent Dr. Sarika Gupta from Apollo Hospital. Before a presentation, can we have the slide for the first pre-poll question on the screen, please? So please select your option and then you have to click on the submit button. Yeah, choose your option, yes, no, or can't say, and then click on the submit option. Now my proud privilege to invite Dr. Sarika Gupta to make a presentation. Ma'am, you have about 6 minutes for your presentation. Over to you.
Sir, these are the results of the poll.
Okay, we'll note them down and we'll see what is the impact of the presentation at the post-poll. Thank you.
Thank you, sir, for the introduction, and I also thank the organizers for giving me the opportunity to speak on the topic. So I think I'm not able to share my slides.
Please try now, ma'am.
Okay. Can you see my slides?
Yeah, yes, we can see yours.
So I'm going to speak on role of sentinel lymph node in high-risk endometrial cancer. Are we ready? So many of the studies have clubbed the high intermediate and the high risk together. So for the purpose of this presentation, I'm going to keep the high-risk histologies and the cancers, the grade 3 endometrioid cancers and the deeply invasive cancers in the high-risk category, as most of the studies define high-risk early endometrial cancer with any one of the factor positive, that is grade 3 endometrioid, serous carcinoma, clear cell carcinoma, carcinosarcoma, deep myometrial invasion, cervical involvement, and significant LVSI. So why are we discussing sentinel node in high-risk endometrial cancer? It is because of the rapidly changing concept in the field of sentinel lymph node biopsy. So earlier it was thought that the deeply invasive high-grade tumors may have an isolated paraaortic metastasis in the range of 16%. So this was a study in 2009. And now the recent evidence suggests that the isolated aortics can be significantly reduced to 1% by high sentinel lymph node mapping rate, ultra-staging, and surgeon proficiency in SLN. So these are the three papers which are a good read for anybody who's interested in this concept that the isolated aortics can be significantly reduced by nowadays. The past concept was that cervical injection of dye cannot map the true sentinel lymph node para-aortic nodes. So with the newest advances, we have found that the cervical injection and hysteroscopic injection have equivalent display of lymphatic pathway and localization of nodes. Cervix is preferred because it is easily reproducible, and the true para-aortic sentinel lymph node rate is less than 1%. So earlier we thought that the false negativity rate may be higher in high-risk disease. But now with all the retrospective studies and the prospective trials, the FNR can be reduced by adhering to good injection techniques, proficient SLN dissection, use of SLN algorithm, and re-injection of the dye. And this is, I think, everybody thinks that high-grade disease metastasizes differently. So the mode of lymph node assessment might affect the survival. So the recent retrospective and prospective trials have again demonstrated that the mode of assessment doesn't affect the survival in high-risk disease. So this is a table which shows the accuracy of sentinel lymph node in high-grade endometrial cancer. And here I would, and this is only for the high-grade, that includes the grade 3, the carcinosarcoma, clear cell, and the serous carcinomas. So among these studies, they have given the breakup of sensitivity, negative predictive value, and FNR in the high-grade patients. So you can see that the FNR is less than 5, except these two studies where it can be reduced to 0 by using the algorithm. So this is a few seconds on this slide, which is about the Centaur slide. The Centaur trial, which is the prospective trial in stage 1 grade 2 EEC and high grade EEC, where the FNR was 4% only. Now, this slide is on the accuracy of SLN on the high risk EC and the high grade EC. So here, all of these are the retrospective trial. One Shrek is the prospective trial. I would like to bring your focus to the FNR again here. We can see that the FNR in these two studies, the Buda and the Pineda, is slightly higher. Why? Because they used Bluda and Technetium. By using studies where they have used the ICG, have lower FNR. So a couple of minutes again on the Shrek trial, which is a prospective trial and very well designed trial. It was done in 2 tertiary care referral centers with 8 year experience in robotics. 5 participating surgeons with more than 100 robotic procedures. They used a new anatomic algorithm, and infrarenal para-aortic lumpectomy was done in 81%. They showed a sensitivity of 100% and negative predictive value of 100%, bilateral mapping rate of 95%, and false negative rate of less than 2% by using the algorithm. They found a isolated para-aortic of 1%. So this study shows that by the surgeon's proficiency, by using a algorithm correctly, by injecting correctly, you can reduce the FNR considerably. You can improve the negative predictive value sensitivity and the bilateral mapping. So this slide is on the oncological outcome of SLN in high-risk endometrial cancer. So the first 3 studies are on the type 2 histology, and the last 2 studies are on the high-risk histology that includes grade 3 and deeply invasive cancers. So I want to bring your focus to these blue areas where here it shows the follow-up. The follow-up in most of the studies is more than I think 24 months, and and I want to bring your attention to the DFS and overall survival. There is no difference in the DFS and overall survival in patients who had sentinel lymph node biopsy and patients who had lymphadenectomy. So I would briefly tell you about this study by Dimitrios, where they studied 2,882 high-risk patients in the National Cancer Database. The median follow-up of the sentinel biopsy only group and the lymphadenectomy group was 29.8 months and 36.1 months. There was no difference in 3-year overall survival between patients who had sentinel lymph node biopsy only and lymphnectomy following the propensity score matching. And there was no difference in survival between lymphnectomy and sentinel lymph node biopsy only groups after controlling for the lymph node status, deeply myometrial invasion, and administration of chemotherapy and radiation therapy. So similarly, another study by Bogani, they found that backup lymphnectomy, even though they identifies 1% more paraiotic nodes, backup lymphnectomy allowed to remove adjunctive positive nodes in 11% of the patient, but there is no difference in DFS and overall survival. And that's how it has brought a change in the SGO recommendations. So it is recommended in all grades and type of endometrial cancer. There is a, in the SGO guidelines, the sentinel lymph node biopsy is acceptable alternative to systematic lymphnectomy for lymph node staging in stage 1 and 2, but site-specific lymphnectomy should be performed in high, intermediate, and high-risk patients if sentinel lymph node is not detected. That means that follow the algorithm. And in the NCCN guidelines also, it says that recent evidence indicates that SLN mapping can also be used in high-risk histologies. And I want to bring your attention to the trials which are coming. The ALICE trial, which will show us the therapeutic value of systematic lymphnectomy along with sentinel lymph node mapping, and the SNEC trial, which is going to tell us about the prognosis of patients with intermediate high-risk endometrial cancer who underwent sentinel lymph node mapping versus systematic lymphnectomy. So my conclusion is that most of the detection rate studies are retrospective with few multi-center prospective studies. The overall survival and DFS studies are retrospective. However, in my opinion, it is acceptable to replace pelvic and paraiotic lymphnectomy with sentinel lymph node mapping in high-risk EC in centers where the surgeon is competent and has a good experience of SLN mapping in low-grade EC. So don't just, when you're starting, do in the low-grade EC, reduce your FNRs, and then start with the sentinel lymph node mapping in the high-risk EC. Thank you.
Thank you very much, Dr. Sarika Gupta, for a very precise and persuasive presentation. Now may we have the post-poll slide, see what has been the impact of the presentation. Can we have the slide of the post-poll analysis? In the meantime, while we're waiting, may I now request our expert, Dr. Shalini Rajaram, she's from Rishikesh AIMS, to give her expert opinion on the subject.
Thank you, Dr. Sharan Chaudhary, for the introduction. And
sorry, may I interrupt? I think Dr. Shalini has been able to, Dr. Sarika has been able to persuade the yes has gone up from 48% to 70%, and can't say has totally disappeared. Thank you very much, Dr. Sarika. Sorry, Dr. Shalini, please continue.
Yeah, thank you, Dr. Chaudhary. And I need to thank Dr. Manish Biswas for having me here. I think Sarika spoke very eloquently, and she did give her, I think, full support to sentinel node biopsy. But to me, I think in high-risk cancers, it is still early days because whatever trials were done in a research setting when they did the sentinel node biopsy, and they also did a complete lymphadenectomy to compare the results. So as per the studies, it says, yes, the sensitivity is very good. The false negative rate is low. The specificity is very good, and it can be studied. But all those trials like Centaur and even SHREC trials have said that it should be done in high volume centers with experienced surgeons. It cannot be generalizable to the general population or the general surgeons, because it does require some amount of expertise. And we still don't have any randomized trial comparing sentinel node biopsy alone with a full pelvic lymphadenectomy, because all said and done in high-risk cancers, they behave differently. We know that the lymph node spread is much higher. We know that peritoneal disease or mental disease also is much more than these patients. So we'll have to look at ultimately at survival rates, recurrence rates, were they in the pelvis, were they distant recurrence rates, before we can actually start doing it. Everybody can start doing it. I agree that in research centers and high volume centers, you can start doing it. And unless we have these last two trials, the ones which Sarika said, which is looking at sentinel node biopsy versus lymphadenectomy in high risk cancers, that's going to, I think, end in 2024, Sarika. Till then, I think with reservation, low risk, I agree. The biology is different. Sentinel nodes is actually a via media. They're not doing any lymphadenectomy at all in patients with low risk cancers, but in high risk cancers, they're like the serous, clear cell, dedifferentiated carcinosarcomas. It's a different kettle of fish. It's a different ballgame. So I think we are not yet ready for everyone to start doing sentinel nodes. Actually, I'm not the debater. I'm just supposed to be the expert commenting on it, but that's my view based on whatever research has happened till now.
Thank you, Dr. Shalini Rajaram, for your expert comments. And now it remains my present duty to thank the speaker and the expert and the audience for participating in this subject. And I now hand over for the next topic to the next moderator, Dr. Bhavna Bansal.
Thank you. Thank you. Thank you, sir.
Thank you, Dr. Saran. I would like to thank all the organizers, and good evening and a warm welcome to everyone. Our next gray zone topic is serous carcinoma of endometrium. Serous carcinoma of endometrium in a polyp with no residual disease in the hysterectomy specimen. Is there a role of adjuvant treatment? Let's start the pre-poll survey. I would request the audiences to participate in the poll. So serous carcinoma of endometrium is a high-grade endometrial carcinoma. I would request the audience to participate in the poll. We have to click on one option and submit the result within 30 seconds. Endometrial serous carcinoma is a high-grade endometrial carcinoma, which is a hallmark seen as a T53 mutation. It is treated aggressively. Many modes of treatment are available for serous endometrial carcinomas. The pre-poll survey ends, and the results are 38% say that observation will suffice, 24% vote for chemotherapy alone, and 29% say that a combination of radiation therapy and chemotherapy is required, and 10% say for brachytherapy alone. Now, I would request our first discussant, Dr. Amish Vora, who is the co-founder and director, Hope Oncology Clinic, Delhi, who will be speaking for the motion that is in the favor of the role of adjuvant therapy in this setting. Over to Dr. Vora, please.
Can I share my slides? Yes. Am I audible? My slides are visible?
Yes, sir.
Okay, let me go to first slide. Okay. Thank you, Dr. Shefali Sardana and Max Group for giving me this opportunity, and happy birthday to Dr. Shefali. Next slide. Okay, I'm doing. So the poster case for this discussion can be 54-year-old postmenopausal lady with per vagina, bleeding investigated, polyp found on hysteroscopy, polypectomy done, serous carcinoma, completion surgery done, no myometrial invasion, stage 1A. The question is, do we give adjuvant treatment to this patient, including chemotherapy? So NCCN, the latest version says any and all serous carcinoma has to be considered in the high risk group. And why should it be considered into the high risk group? Because if you see Ebeloff's Clinical Oncology 6th edition textbook in 2020, they say recurrence rates for uterized serous carcinoma without myometrial invasion treated with observation alone can have as much as 0 to 30%. On the right-hand side of mine, diagnostic pathology, that is cancer genome atlas molecular classification. It says that the molecular features of serous carcinoma, even in intraepithelial neoplasia stage, it features with high-grade serous ovarian carcinoma and basal-like breast carcinoma, which are aggressive. Now, what happens to the clinical risk? Now, there's a 2020 editorial by Memorial Sloan Kettering. The title is very interesting. Should we give chemotherapy in non-invasive endometrial serous cancer? And they are saying this because 5-year survival rate for early serous carcinoma is 75% compared to 86%. That is 10% more for grade 3 endometrial carcinomas, because 40 to 60% of patients, even when they are confined to polyp, can have extrauterine metastasis. And that's the reason stage 1A in NCCN says systemic therapy with vaginal brachytherapy. Now, there are multiple retrospective studies which are seen, and inclusion criteria stage 1A without myometrial invasion, be it Havrilesky, Mayo Clinic, Memorial Sloan Kettering, British Columbia Tumor Registry. All these were retrospective. They said observation alone may be sufficient. On the other hand, 9-center study and Mahadevi et al. Presented in the retrospective data that chemotherapy is better in stage 1A without a myometrial invasion. Remember, including GOG studies, all these studies have small numbers. So this Dimitrios doctor from Pennsylvania University has one of the largest registry data in stage 1 uterine serous carcinoma confined to endometrium from National Cancer Database. 4,43,000 uterine cancers, 27,000 serous carcinoma, 8,000 stage 1, 5,800, at least 10 lymph nodes up to periaortic dissected, 1,900 without myometrial invasion, and they included 1,709 in the study. 50% of the patients were only on observation. What did they find? Radiation plus chemotherapy is the best, followed by chemotherapy, followed by observation. If you take adjuvant chemotherapy alone, 10% difference in the overall survival in stage 1A without myometrial invasion. So what I'm concluding is that serous carcinoma is more aggressive. It forms less than 10% of endometrial cancer, but accounts for 80% of deaths in endometrium. No large RCTs available. Retrospective data are small. OS data can be skewed, but one of the largest database of serous carcinoma is from National Cancer Database, and it suggests chemotherapy or the adjuvant treatment, including radiotherapy, is useful in stage 1A serous endometrial carcinoma without myometrial invasion, even in the form of polyp. Thank you so much.
Thank you, Dr. Bora. Now I would like to invite our next discussant, Dr. Pooja Nandwani Patel.
Hello, hi.
Senior Consultant and Head, Department of Radiation Oncology, Sterling Cancer Hospital, Ahmedabad. She will be speaking against the motion, like against the role of adjuvant therapy in this particular setting. Over to you, Dr. Pooja.
Hello, good evening. Can I have the rights to share the screen? It says you cannot start screen share while the other participant is sharing.
Yes, ma'am. Share, please.
Yeah. Good evening, everyone. At the outset, I would first of all like to thank Dr. Charu and Max Hospital for inviting me today for this wonderful discussion. Is my slide visible and am I audible?
Yeah, ma'am.
The slides are visible, right?
You are audible, but slides are not visible.
Slide is not visible, ma'am.
One second, let me reshare.
Ma'am, have you shared the slides, sent the slides to the technical team?
Yeah, it is there. Yeah, it is there.
Okay, so Avinash, can you share the screen if ma'am is not able to do?
Do you have the screen sharing rights?
Yeah, it is not accepting actually. I hope Dr. Amish has already stopped sharing the screen, right?
Yes.
Yes, ma'am, yes.
They stopped for my behalf.
Okay. Or otherwise, if they do have at the back end only. So if the organizers can start my slides.
Let us
please.
check, ma'am. Let us check. Please allow some time.
Yeah.
So, ma'am, you in the meantime, you if you have your screen available with you, so you can start discussing, and I think the technical team will take over then. So, in the interest
Try
of
one
time,
more
sorry,
time, ma'am. Try one more time. It will come.
Yeah. I stopped sharing and reshared also, but that's not working actually.
Sharing now.
Yes. Yeah.
Yes,
Is it
ma'am.
there?
It is visible. Yes.
Okay.
Coming
Great.
up.
Great. Sure. Thank you.
Yeah, now it is visible. Perfect.
Yeah, I thought Dr. Amesh would have ended saying that now it is okay if there is no slides. Anyways, so I have a tough job, but I will try. I think I'll try to do justice to my role. So let us see the evidence in a chronological fashion. So this is a paper published in the Gynec-Oncology 2007, which talks about the role of symphytic lymphadenopathy and adjuvant therapy in stage 1 uterine papillary serous carcinoma. And if we see this paper, there were about 42 patients. And because this is a paper of 2007, probably that's why they had 1A as 15 patients, 1B 21 patients, and 1C as 6 patients. 81% of the patients, that is 34 patients, underwent lymph node dissection with the median nodes dissected 40. 69% had omenectomy and 45% had peritoneal biopsies. The substage 5A overall survival was 100% in stage 1A, 89% in stage 1B, and 60% in 1C. There were no recurrences detected in the 15 patients who were in stage 1A, irrespective of the adjuvant therapy offered. So the conclusion from this study was that observation can be an option for patients with stage 1A UPSC confirmed by systemic lymphadenopathy. Patients with the comprehensively stage 1B and UC are candidates for chemotherapy and vaginal brachytherapy to prevent the HPR and VR. Now let us come in for the few papers which are seen in the last decade. That is, this is a paper published in the Gynec-Oncology 2013. It talks about the early stage papillary serous or clear cell carcinoma confined to or involving an endometrial polyp, outcomes with and without adjuvant therapy. Let us have a close study of this, close observation of this study, which is about 51 patients. They had stage 1A pure UPSC or pure clear cell or mixed endometrial carcinoma from 1995 to 2011. Again, because of the FIGO staging at that time, stage 1 had the disease which was with no myometrial invasion, but after the revised staging in 2009, even half myometrial invasion was also included. The results what was seen was that the cytology was done in about 40 patients. The omental biopsies was performed in all patients. The patient constitution in the terms of histology was UPSC in about 34 patients, that is 66.7%. And no residual disease was seen in the total hysterectomy in about 7 patients, that is 14%. Out of these 51 patients, 41 patients were in the observation category, and 10 patients were in the adjuvant category, where 3 of them received chemotherapy, 1 vaginal brachytherapy, and 6 were sequential chemoradiation. The recurrence pattern was seen was 3 out of the 41 patients who were given the surveillance option, and 1 out of the 10 patients who were being offered the adjuvant therapy. If we study the recurrence pattern in these 4 patients were, the one patient who was being given the adjuvant therapy was a mixed UPSC, whereas the 3 patients who were given the surveillance option, 2 again were of the mixed UPSC and the clear cell histology, while only 1 was of the pure UPSC. So the conclusion from this paper was that patients with limited UPSC or clear cell disease involving a polyp and who have a complete workup do really well without any adjuvant therapy and have the same recurrence rate as to UPSC SCC stage 1A disease. Another paper published in 2016, which is from the Memorial Sloan Kettering Center, and it talks about the assessment of the prognostic factors, adjuvant treatment, and outcomes of stage 1A polyp limited versus endometrium limited type 2 endometrial carcinoma. If we see, these were the patients which were being taken from 1995 to 2012. 85 patients were there. Out of these patients, they all underwent hysterectomy, salpingo-oophorectomy. They had a lymph node assessment, and they were purely stage 1A endometrioid carcinoma with no lymphovascular or myometrial invasion. The treatment options offered were either they were kept on chemotherapy or radiation, which include both the vaginal or the pelvic. And the third group was where there was no adjuvant treatment being offered. The conclusions were the 3-year progression-free survival rate was 94.9%, and the 3-year overall survival rate was 98.8%, concluding that the clinical outcomes of surgical stage 1A type 2 polyp or endometrial limited high-grade epithelial endometrial carcinoma are equally favorable regardless of the histological subtype or the adjuvant therapy offered. Now, if we see this paper again and we try to study the recurrence pattern, these were the patients where 20 patients were given the option of surveillance as compared to the rest of the 64 patients given either radiation or chemoradiation. The 3-year overall survival in the surveillance arm was 100%, and even the 3-year progression-free survival in the surveillance arm was 100%. If we study the recurrence pattern in detail, what we see is about 3 patients were polyp limited, out of which 2 were serous and 1 was mixed, whereas the 2 endometrial limited out of 1 was serous and the other was clear cell. So the conclusion was that clinical outcomes of surgical stage 1A type 2 polyp or endometrial limited high-grade epithelial endometrial carcinoma are equally favorable regardless of the histological subtype or the adjuvant therapy received. Of course, the benefit of the adjuvant therapy in the selected group needs to be determined. Now, this is a very recent paper published in 2019 in the American Journal of Clinical Oncology, and it talks about the uterine papillary serous carcinoma arising in a polyp, a multi-center retrospective analysis of about 75 patients, a study done from 2003 to 2013. There were about 75 patients. This was from 7 Italian gynecology oncology centers. What was being seen that these patients, they were properly surgically staged, and the adjuvant therapy was offered in about 25 patients, whereas surveillance was kept in 50 patients. The recurrence pattern was 6 patients who had the surveillance option recurred, whereas 2 patients who were on the adjuvant therapy, they recurred. So the conclusion from this study was that stage 1A patient, completely surgical staging done, those who have not received the adjuvant therapy, the recurrence rate is about 5.3%, versus those who received the adjuvant therapy is 12.5%. However, the conclusion also stated that surgical staging was the very important thing which really correlated with the risk of relapse. And that is why the conclusion said that though the international recommendations on the management of the uterine papillary serous carcinoma are not uniformly followed in daily practice, the extent of the surgery seems to be associated with lower recurrence rate. Also, when we are talking especially about the papillary serous carcinoma, which is confined to polyp or the endometrial surface. So to conclude, I would say that comprehensive surgical staging defines the disease biology and guides the selection of adjuvant therapy. There might be a small subset of patients who may recur, and for this cohort of patients, molecular profiling and subsequent management with rationally targeted therapy should be pursued. However, surveillance is definitely an option for a stage 1A high-grade endometrioid carcinoma, which is having a disease which is just limited to the polyp or the endometrium with no myometrial invasion and negative washings. So I think if I repeat this question, or probably the poll would really answer what is the adjuvant therapy to be offered for or not for these type of patients.
Thank you, Dr. Pooja, for your excellent talk on this particular topic. It was an excellent discussion by both the discussants on this particular gray zone area. Now moving to the post poll. Let's see if there is a change of opinion after hearing the opinion of the discussants. The poll starts now. All the participants are required to vote and click on the submit button. So now 31% of the people think that it should be observed, and 44% think that they should be treated with radiation and chemotherapy both. So now, after discussing these results, I would like to invite our expert for the session, Dr. Vinita Goyal, Director, Radiation Oncology, Fortis Hospital, Shalimar Bagh, Delhi. Over to you, Dr. Vinita.
So good evening, everyone. Thank you, Dr. Bhavna, for my kind introduction. I think it's a very rare situation that we are talking about, and that is why it is falling into the gray zone area. And from the poll itself, it is quite clear, that the people are divided in their opinions. And about a third think that observation is fine, a third think chemotherapy alone, a third think chemotherapy and radiation therapy, both are required. I think stage 1A serous carcinoma confined to polyp is a very, very rare situation. So whatever evidence is available only in the form of small series. There is no clear evidence as presented by both the presenters in favor or against adjuvant treatment. And it is very unlikely that in next decade also, unless something path-breaking comes, we will have clear answers as to how we should be managing it. But in my own personal opinion, outcome here is likely to be dictated by biology rather than stage of the disease. For an aggressive cancer like a serous carcinoma, I think biology is more important than stage to decide on the treatment protocol. For example, suppose I see a glioblastoma, GPM, or an anaplastic carcinoma of thyroid. The treatment option will not be dictated by the size of the tumor or whether it is completely resected, not resected. It is the biology which is going to decide the outcome. So maybe the answers are, I think this is going to be a gray zone for some more time till we have clarity, and maybe NGS, etc. will give us better clarity. So that's my take on this. Thank you so much.
Thank you, Dr. Vinita, for your expert comments. I think the outcome is that it remains a gray zone only whether to treat or not to treat. Thank you. So it was a nice discussion on this topic by Dr. Amish, Dr. Pooja, and an expert comment by Dr. Vinita. I would like to hand over to the next moderator, Dr. Shefali Sardana.
So good evening, everyone. Wonderful discussion so far. And now we move on to next question without wasting much of the time. Can we display the question? So the question, should PARP inhibitors be given in all newly diagnosed ovarian cancer patients as a maintenance therapy? We still are on the verge, whether only advanced. So please click your opinion and submit it. So this is ever discussed topic. Once we have stage 1, stage 2 patients, then the discussion starts. Okay, do we have enough evidence to state whether we should have PARP inhibitors in all or BRCA positive only or in the advanced stage only? So to set the context going, I think we'll have the results. Yeah. So 25% say yes, 67% say no, and 8% still are not sure of their decision. So I would like to invite our first discussant, Dr. Vineet Talwar, who is Director Medical Oncology, Rajiv Gandhi Cancer Institute, Delhi, and sir would be speaking for his viewpoint in the motion that all patients of newly diagnosed ovarian cancer should have PARP inhibitors as maintenance therapy. Sir, I welcome you. Please take over.
Thank you, Shefali, at the outset. And let me see if I can share my slides. So, the usual word, can you see me? Can you hear me?
Sir, we can hear you. Limit yourself to 4 minutes, I request.
Yeah, sure.
Thank you,
sir. You've given me full 4 minutes to discuss on such a small topic. Well, I'll do full justice to that. Amish is smiling. So, should PARP be given to all comers? This is the schema. First, we'll go to BRCA 1 and 2 mutations. Then we'll go to BRCA plus HRD. Then we'll go to BRCA plus HRD plus HRP. And then, of course, chemo plus all comers. So this was the SOLO trial in which patients continued to have a benefit. This was basically olaparib versus placebo olaparib, which is a PARP inhibitor. And the latest timelines where you see that even after 5 years, 48% of patients were progression-free at this point of time. So treating BRCA mutated patients, the SOLO trial reduced the risk of progression or death by 67%. So this is nothing new. Everybody who has a BRCA mutation, definitely. So we got a little greedy. We thought we'll see whether in BRCA1 and 2 and HRD population, does it help? So this was the Paola trial in which patients who had a CR or a PR, they were pitted to olaparib plus bevacizumab versus bevacizumab versus placebo and bevacizumab. And they found out that there was a marked difference in the progression-free survival. In the BRCA mutated patients, yes, obviously you find that there is a difference, but in those patients also who were HRD positive, you found that there was a significant difference in the progression-free survival, that is 19.5 months, and it was very good hazard ratio of 0.33. So now you have patients who are BRCA mutated, you have patients who are HRD. Now the third group was it significant in the HRP group also, which is the point of discussion. That is when you combine all these three, you have the all-comers in these patients. So this was the primer trial in which patients were given chemotherapy, and then after that they were pitted to niraparib, which is another PARP inhibitor, versus placebo. And this was continued till 36 months. And the primary endpoint was progression-free survival. And it showed a longer PFS benefit with a hazard of 0.62 in all comers. And even in the homozygous, homologous recombinant proficient patients, you had a survival difference of about 3 months with a HR of 0.68. Although this was lowered as compared to the other groups, that is HRD and BRCA positive, which is very, very logical. Possible complementary mechanism to the PARP-regulated gene transcription was the ribosome biogenesis and the immune activation. So this could have been contemplated as to the mechanism in these group of patients. Then we got further greedier that whether should we combine chemo with the PARP inhibitors, and this was seen in the Velia trial, in which veliparib, another PARP inhibitor, was seen. And that showed chemotherapy plus veliparib followed by maintenance. It had a longer PFS than only induction chemotherapy in the intent to treat population. Mind you, it is the all comers here. And the mechanism here was postulated was that the chemotherapy induced bone marrow damage augmented the cellular reliance on the DNA repair, which leads to increase in the PARP efficiency. So to conclude, I would like to say PARPI, that is PARP inhibitors, are here to stay. BRCA mutated and HRD status are strong predictors of PARP inhibitor activity. But at this point of time, I would say more than the BRCA or the PARP, it is the platinum sensitivity which decides whether these patients are more susceptible to the PARP inhibitors or not. Not only the BRCA and the HRD. BRCA definitely, but HRD also. Testing is important, but then at the same time, logic says that you have to use the platinum sensitivity as the sheet anchor or the hallmark whenever you decide these patients are to be taken. And whenever you use these drugs, they have a well-tolerated quality of life, which is also very important when you give this treatment. There is a stratified magnitude of benefit, which I would say that first would be, maximum would be for the BRCA mutated, then the HRD, then platinum sensitive non-HRD also, and then of course the others. So I think I'll rest my case here. Thank you.
Yeah, thank you so much, sir, for concluding in time. And now I would like to invite Dr. Vikas Talreja, who is Senior Consultant Medical Oncology in Regency Hospital, Kanpur. So Dr. Vikas will be talking his viewpoint against this topic. So Dr. Vikas, can we have your viewpoint, please? Avinash?
So please unmute yourself. Yes, ma'am, he's online, but is muted. So please unmute yourself.
Dr. Vikas, please unmute. Dr. Vikas, can you please unmute yourself? We can't hear you. Avinash, Dr. Vikas is there?
Yes, ma'am. Yes, ma'am, is online.
Yeah, so he's just trying to unmute. So Avinash, if he's not able to do that, can you unmute him and display his slides till that time?
I just talked. He's online.
I suppose I'm sorry. Am I audible right now?
Yeah, yeah.
And can I have my slides or I need to share it?
So either ways, which you are comfortable with.
I've already shared with it. So can we?
Yeah. So Avinash, can you display the slides, please?
If it takes some time, or I should do it from my
Yeah,
side?
till the time yeah, he starts displaying, you can start your discussion, please. Yeah.
Or I will share it from my screen only. Perfect. Very well said. So the topic that has been given, and I believe it is a burning topic for us, for everybody right now, that the PARP inhibitors should not be used in the ovarian cancer as maintenance. And as we go, the typical history of the just a second. If it's difficult to share, then I will share from my side only. Okay.
Avinash?
Yeah, yeah.
Is my screen visible?
Yeah, Dr. Vikas, it is
Perfect,
visible.
perfect. So the typical history as we go for the ovarian cancer is we do the primary surgery or the interval debulking surgery, plus minus the chemotherapies and the bevacizumab. And we follow these patients till they relapse, which most of them, 70 to 80% of them do tend to develop. And most of them we tend to classify as platinum sensitive or platinum resistance based on the duration of the response, as how early they relapse, whether they relapse within the 6 months or they relapse more than the 6 months. And that's why we classify them as a platinum sensitive or a platinum resistant. And as we know that we expect a something that whether the therapy which we are going to give is going to do something to prevent that relapse or going to have an impact in the treatment course of it. And that's where we expect the maintenance therapy to be there. It should provide a therapeutic benefit extending from either the disease-free period survival. It should not impact the quality of life in the long term. We know that there is a not strong data as how the PARP inhibitors have a mechanism of resistance down the lane. The very important, especially while the patient has got any disease, that since the disease is absent, we shouldn't be doing something which should deteriorate the quality of life. So we are giving some therapy which we don't have skeptical reasons for whether the disease-free survival or the overall survival, the benefit is there. But we definitely have a reason that the quality of life does deteriorate with the maintenance therapy, because in the maintenance therapy, when we discuss these options, the patient doesn't have a disease right now, and we give a potential promise of some therapy which is going to be toxic, but definitely a questionable therapeutic efficacy. And also very important in Indian terms, because the cost benefit ratio should be analyzed across these PARP inhibitors, because we know that with the incremental cost we occur, the questionable benefit we have, it should be discussed in details in most of these patients, and 99% of them tend to opt out of it because of it. And that's here, if we look at these data, that individual patient data analysis we did across the 3 years, that most of them are in this age group. So 21% of them tend to relapse within the 6 months and they are platinum resistant. 22.5% relapse within the 6 to 12 months of this range, that's they are partially sensitive, and 31% relapse more than 12 months. So they are those which we classify as platinum sensitive. Now, those who are platinum resistant are the primary resistant. 21.8% which we discussed are those who relapse within the 6 months. The secondary resistance is whether it's within the more than 6 months but less than a year, or it's more than a year. So around 80% of those, out of this, half of them, 54, are those who relapse after 6 months, and 31% are those who relapse after a year. And the potentially curable patient that we discussed are those who are 24% who never relapses, and that's the 5-year PFS of it. Now, as we see,
Dr. Vikas, I think we need to conclude.
Yeah. So when we see across these chemotherapy regimens we discussed across, the bevacizumab had always shown that there is no data for, you look at these curves exactly matching, no PFS, no OS benefit. So no role for first-line bevacizumab as for the same. And across the PARP inhibitors, if you look at the hazard ratios for it, a questionable survival benefit, a definitive deterioration in the quality of life, and definitely those who are unselected BRCA positive patients, no DFS or OS benefit, and one trial delivering a results, another trial failing those results, the same biology. I believe we should be questioning whether we are selecting the right patients for the right drug for a potential cure in this, because we aren't changing the natural course of the disease. So the cost implications, the confusion of testing, and we need to look at whom are the patients which we are potentially benefiting. So out of 100 patients, I believe only 6 to 7% patients of those patients who are actually having those BRCA mutation which have a potential benefit out of it, out of those platinum sensitive, these are there. So
right, I think
I would like to conclude.
Yeah, thank you, Dr. Vikas, for a wonderful summarization. And can we have the post poll now? So has it changed the mind of audience? Let's see. Yeah. So in the meantime, the post poll results are available. I would like to invite Dr. Shyam Agrawal sir as an expert on this topic. And like you can see the results, the percentage of people saying no has actually more increased, and can't say, I mean, that has surprisingly also increased, doubled up. So let's hear from our expert. What does he has to say on this topic? Sir is a senior consultant medical oncology in Sir Gangaram Hospital, and he needs no introduction. So sir, please, your viewpoint or your expert opinion on that. Thank you.
So I voted for no, which is what the majority have clearly said, and the numbers have increased. But we've come to a stage when a patient with advanced stage gets a CR or a PR, we must do the BRCA testing. And currently HRD testing is also becoming popular, because those are the category, and 50% of these patients are going to be HRD positive. So those are the patients who are likely to benefit from PARP inhibitors and a combination of bevacizumab as per the Payola study, So I think we can't get away from PARP inhibitors. And, if you have the availability of newer drugs like niraparib, they have also shown that they can be used as a single agent in the HRD positivity. So I think patients who are negative for HRD, they are the patients who should not be catered for, PARP1, and as Vikas pointed out, financial toxicity is also there. Although in the primer study they had all comers, but I think if you look at the hazard ratios for HRD negative, so they're not very strong and they don't support the use of PARP inhibitors. So I think the issue currently is how to look for HRD testing. So the myriad testing is the one which is so very expensive, not readily available. But I think you do have cheaper alternatives becoming available from Strand Life Sciences, and some people are also doing gene panel based HRD testing. So I think this field is very, very rapidly evolving. Must keep an eye on it. The drugs are available, and I hope there is data on rucaparib also in the first line maintenance, which is the cheapest PARP inhibitor available to us. So I think we can't close our eyes to PARP inhibitors in the first line maintenance, and they are really, really drugs for patients who are platinum sensitive and who harbor BRCA1, BRCA2 or HRD positive. Thank you.
Yeah, thank you so much, sir. So really, I mean, it was wonderful to listen from all of you. So I invite Dr. Swasti to moderate the next question session. So Dr. Swasti, please.
Thank you, Dr. Shefali, and thank you to the entire organizing team of Gynonc Maxcon 2021. Wonderful show. And the topic today for the contention in the gray zone is HIPEC beneficial in primary CRS with CC0 resection in stage 3C ovarian cancer. And before we have the discussants on board, can we have the pre-poll questions, please? So I would request everybody to vote within 30 seconds. You've got 3 choices, yes, no, and cannot say, and just submit your results, and then we'll discuss it once the discussants have put up their points. So I think everybody submitted. Yeah. So we see that 33% people feel that HIPEC should be incorporated into the primary CRS with CC0 resection, 58% no, and 8% cannot say. So to begin today's gray zone, I would like to invite Dr. Rupinder Sekhon. She's Senior Consultant and Chief of Gynae Oncology at Rajiv Gandhi Cancer Institute, Delhi. Ma'am will be speaking for the motion. Dr. Sekhon, ma'am, are you there?
One
Yeah.
second, just trying to share my slides.
Yes, ma'am.
Can you see my slides?
Yes, ma'am, we can see. We can see.
Yeah. So at the outset, thank you once again to Dr. Harit and Manis and Kanika and Charu and a whole lot of other friends for this opportunity and for talking about something which is quite my favorite. And let's see, but unfortunately, we do not have too much evidence for all of this. Though, please don't think that I'm starting on a defeating note. It is just that I'm just trying to be fair and square. So is HIPEC beneficial in primary CRS with CC0 resection? Let us see. So what exactly is HIPEC? One second. Slide is not moving. Sorry. So is the slide moving?
Yes, ma'am.
Yes, it's moving.
Is the slide moving? Okay. So what is HIPEC? HIPEC is basically heated intraperitoneal chemotherapy perfused into the abdomen immediately following surgical debulking in an open abdomen. Why is HIPEC used? Because heat has a direct cytotoxic effect and it targets the remaining microscopic residual tumor at the time of cytoreduction. There's also increased exposure of the poorly vascularized tumor to the high concentration of chemotherapy. The blood peritoneal barrier also limits the passage of this high concentration of chemotherapy, minimizing systemic toxicity while maximizing local effects. Heat, again, to reiterate, is directly cytotoxic and improves the chemotherapy penetration into the tissues and is synergistic with commonly used chemotherapeutic agents. So what is the rationale for using this for PDS? That is an upfront primary debulking surgery. Now, HIPEC will immediately, if we do HIPEC immediately following surgical debulking in an open abdomen, first of all, the abdomen is completely free of adhesions. Secondly, at this point in time, the tumor burden is at its lowest. It also has the advantage of early treatment of residual peritoneal disease before the tumor develops a profile of acquired resistance to platinum as a result of cellular selection in response to repeated courses of systemic chemotherapy. What the surgeon does not see is what actually kills the patient. So there is a strong rationale for loco-regional treatment in CA-ovary cases. So how are they treated? First of all, there is treatment of macroscopic disease, as we all know, by doing a very good cytoreductive surgery and peritonectomy. Treatment of residual microscopic disease is by HIPEC, and treatment of systemic disease is by IV chemotherapy. So in this paper, which was published in 2019, they found that in 26 patients, when biopsies were taken from macroscopically healthy peritoneum, at the end of CRS, 26.9% presented with microscopic peritoneal metastasis. Not only that, after mathematical analysis, the probability of microscopic peritoneal metastasis was as high as 98%. So that means almost 100%. Yet another paper showed that there is early tumor regrowth which contributes to the impaired survival of patients. This was shown by this intergroup trial of AGO-OR12, where of the 689 patients where complete resection was done, tumor was observed in 28% and 22% of patients undergoing radiologic and integrated assessment, respectively. Now, there are two explanations for that. Either the post-operative residual lesions, they were overlooked by the surgeon, or there is early post-operative tumor regrowth. This latter explanation is supported by the length of the interval between the surgery and the imaging being an independent factor associated with discordant assessment. Furthermore, the observation that survival of this subgroup, that is the second subgroup of patients, was not as poor as the survival of patients with residual disease at the end of the surgery supports the tumor regrowth hypothesis. So obviously, we have to look at the remaining tumor even after we have done a lot of macroscopic, so to say, a CC0 resection. That means this epithelial ovarian cancer needs still upfront loco-regional treatment. And yes, there is still a significant unmet need in the first-line therapy for ovarian cancer. Now, in 2018, this landmark paper was published by Van Riel, wherein she showed that by introducing hyperthermic intraperitoneal chemotherapy in ovarian cancer, that is HIPEC, the recurrence-free survival improved by about 4.5 months if we added HIPEC to surgery. Also, the overall survival was 45.7 months compared to 33.9 months if no HIPEC was introduced. So after this, it became clear that HIPEC is useful. And this was introduced as a standard of care or as a guideline in the NCCN recommendations as early as 2019. Now let us see, when should we give this HIPEC treatment? In this trial, it was shown that upfront debulking surgery, when we compare it with interval debulking surgery and combine it with HIPEC, the PFS and the OS, there was no difference in the two. However, in the upfront debulking surgery group, that is the UDS group, the recurrence-free survival was much more, though not statistically significant, but the recurrence-free survival was much more. So what does that translate into? That translates into a better quality of life. And after all, that is what we are looking for in ovarian cancer treatment. Isn't that so? Next. So in this Chinese oncology group paper, they showed where they had analyzed more than 500 patients, out of which 425 underwent primary debulking surgery along with HIPEC, and 150 underwent primary debulking surgery alone. the survival was 49.8 months in the first group versus only 34 months in the group where no HIPEC was added. The French study also showed that in patients who had severe disease, that is an advanced epithelial ovarian cancer, the overall survival was 35.4 months when we add HIPEC to the primary surgery. In another systematic review and meta-analysis published in the European Journal of Oncology, they showed when HIPEC is added to CRS plus chemotherapy, the overall survival improved significantly. Next. So now that we have shown that by adding HIPEC to the primary debulking surgery, there is a significant improvement in the overall survival. Let us see how does this work out in the zero of bevacizumab and PARP inhibitors. This study, which was published in 2018, it showed that in upfront HIPEC plus CRS surgery, if we were to add bevacizumab, in no terms is the toxicity increased or any such complications occur which are not managed easily. There is only about 20% of grade 3 and 4 morbidity with a median hospital stay of only 8 days. So in this position statement, which was published by the Brazil group, they said that can HIPEC be used against platinum resistance and for inducing sensitivity to PARP inhibitors in ovarian cancer. They showed that HIPEC can reverse or circumvent the resistance to platinum-based chemotherapy. Not only that, mild hyperthermia induces degradation of BRCA2 and inhibits homologous recombination. Of the upcoming trials,
ma'am, 4 minutes are up.
Yeah, just 30 seconds. So in this upcoming trial, they're going to publish their results in the year 2026, wherein they have two arms where they're adding HIPEC and there's going to be no HIPEC, and we are waiting for the results to be published. So there is a strong rationale for primary CRS plus HIPEC. Experienced centers need to do this, where very meticulous patient selection needs to be done, and we need to evaluate all of this in randomized controlled trials. Let me quote Hippocrates, who says that those whose disease medicine cannot cure, iron cures, and those which iron cannot cure, fire cures, and those which fire cannot cure are to be reckoned wholly incurable. So let us use HIPEC, which is basically fire control, is the fire cure. Thank you so much.
Thank you, Dr. Rupinder, for your excellent deliberation and bringing out the salient features. We'll move on to our next discussant for today's Grey Zone, Dr. Monisha Gupta, Senior Consultant Gynae Oncology at MICC Shalimar Bagh, and she'll be talking against the motion. Dr. Monisha, please.
Thanks, Dr. Swasti, for the kind introduction. And first of all, I would like to share my screen. Is it visible to all the participants?
Yeah, yes, you can just put it on slideshow, please.
Yeah. And am I audible?
Yes.
Okay, thank you. Just here. So thanks, Dr. Swasti. And first of all, I would like to congratulate the organizers, Dr. Manas, Dr. Shahrukh, Kanika, for the excellent academic feast, and to give me an opportunity to present my views on this hot and debatable topic. So let's start. HIPEC, that is the hyperthermic intraperitoneal chemotherapy, has been in the recent decade, has been taken as a complete cure or as a cutting edge technique for the cure of ovarian cancers, but it really is not. And recently it has been recommended by all the experts in all the settings of ovarian cancer, primary as well as recurrent. But we need to be more careful because HIPEC is a complex procedure where the more of the technical aspects needs to be considered. Still, we don't have a standard single protocol across the globe to deliver the HIPEC techniques. And it's true that we need to evaluate a lot of different parameters. We have a lot of variations in different parameters in HIPEC, and we need to evaluate them separately to know the optimal way of delivering the HIPEC techniques to our patients. So if we go to review the literature on HIPEC in ovarian cancer, in 2015, we had the first prospective randomized phase 3 trial on HIPEC in the recurrent setting of ovarian cancer, where the HIPEC shows a significant PFS and OS benefit in both the platinum resistant as well as the platinum sensitive cohorts. Then 3 years later, the Vandrel, they did a RCT in 2018 where they show a significant 4 months difference in PFS and about 12 months difference in the OS as shown by Dr. Upender. And this is the trial which is considered as a landmark trial, and it states that there might be some usefulness of the HIPEC in the ovarian cancer in the interval debulking setting. But this trial has got a lot of limitations. There was a lack of stratification of the patients in the FIGO setting as well as in the tumor BRCA status. There's a lot of heterogeneity in both the arms in terms of maybe the more chemo-resistant patients in the HIPEC arm. So despite a lot of the limitations, it shows a significant difference in favor of HIPEC. And this is the latest evidence, the retrospective evidence in the favor of HIPEC in the primary setting for the ovarian cancer. And this is by the Chinese peritoneal oncology group, where about 789 patients were enrolled from prime centers and about 584 were eligible for the data analysis. Out of them, about 450 underwent surgery along with HIPEC and about 150 underwent for surgery alone. But it was a closed technique with an unusual protocol of a low dose cisplatin with about 50 milligram per meter square, and it was repeated on day 1, 3, and 5. So this was a very unusual way of giving HIPEC, which cannot be generalized to other centers, where a single time HIPEC is being done along with the primary cytoreductive surgery. So this cannot be generalized. Also, it has got a lot of limitations. First of all, it was a retrospective study with lot of selection as well as analytical bias. Second, there is a lack of homogeneity in both the groups, going surgery as well as surgery plus HIPEC, where the more of the chemo-resistant group were there in the surgery arm. There was no stratification before or after surgery because it was a retrospective study. There was no data information regarding the tumor genomic status, that is most important, the BRCA status. There was no information about the pattern of recurrence or the surgical outcomes of the patient. No information about the use of any contemporary agents in the post-operative chemotherapy regime. And it was a concerning that about less than 50% of patients were able to complete all the 6 cycles of post-operative chemotherapy. And also, there was no statistical superiority of adjuvant HIPEC in a 3-year overall survival in patients with incomplete surgical effect, showing that the complete surgery is still the most important parameter for survival outcome in ovarian cancer. So despite all the limitation, it shows a significant difference in the median survival in all the patients as well the patients with a complete cytoreductive effort. But we have seen the similar results in the colorectal patients, where a similar retrospective multicentric French study was there by the colorectal group, where 523 patients were randomized between HIPEC and no HIPEC. The results were phenomenal, but when they did a similar randomized trial, phase 3 trial in the similar group with HIPEC and no HIPEC, there was no benefit of HIPEC in the randomized trial, and they stated that the cytoreductive surgery alone should be the cornerstone of therapeutic strategy for the curative intent. Similarly, another randomized phase 3 study by the colorectal group published in 2020, in which they stated that the systematic second look surgery along with oxaliplatin HIPEC did not improve the survival outcomes, and the standard surveillance is still the gold standard. Another
Dr. Monisha, your 4 minutes are up.
Just 5 minutes, just 1 more minute. Another study was the GOG group, another interesting one, where they randomized the 2 IP regimes along with the IV protocol in the patients with advanced ovarian cancer in primary setting. And this they include, and all the 3 arms, they received the contemporary bevacizumab in the adjuvant setting. And again, there was no benefit of IP chemotherapy versus IV regime after the addition of bevacizumab, and they concluded that it is the bevacizumab combined with IV which is more appropriate rather than IP chemotherapy. So yes, we should not offer HIPEC. We are not ready for it in the primary setting, and we still need a randomized controlled trial, which is on its way in the form of OV HIPEC 2 trial, which has randomized us patients into HIPEC and no HIPEC before the surgery, as well as they are randomized. They are giving the patients the post-operatively bevacizumab or other contemporary agents according to the guidelines. Just if we just have a glance, the last slide, if we just have a glance in the of the HIPEC protocol in the recurrent setting, we have a discouraging data of HIPEC. We have a 3 randomized trial with no HIPEC, and we can see that the PFS in the no HIPEC group is 18, 18, and 17, and with the MSK HIPEC recently published last year has got a 14.3 months PFS, which means that the addition of HIPEC did not give a survival benefit as compared to the addition of PARP inhibitors or bevacizumab or other contemporary agents, which gives a PFS benefit, and that is what we need in ovarian cancer. And this is just a recent RCT of phase 2
Sorry to
trial.
interrupt, Monisha.
So just to conclude my presentation, we are not yet ready for the HIPEC in primary setting. There is no robust data supporting the role in the primary setting. Only retrospective data is available. Recently, we have a discouraging result in recurrent setting. HIPEC improves outcomes after NSCT, but needs to be evaluated in a more contemporary way with the addition of contemporary agents. And we still need a BRCA status for a tumor genomic certification. And hopefully, OV HIPEC 2 trial will give all the answers. Thanks.
So thank you, Dr. Monisha, for your presentation. And before we go on to our experts, let's just look at a quick post-poll survey. Same question, HIPEC in primary CRS with CC0 stage 3 ovarian cancer. Are we ready yet? Yes, no, cannot say. So can we have the results? So I think makes more points. We're going forwards towards no, 65% of majority. I welcome Dr. Amita Maheshwari. She's the professor and head at Tata Memorial Center Division of Gynae Oncology, Mumbai. And ma'am will be talking about and summing up as an expert for this gray zone.
So thank you, organizers and Dr. Swasti. And thank you, Dr. Rupinder and Dr. Monisha for presenting excellent data and putting up a great debate. So although it may sound logical to add chemotherapy, heated chemotherapy to clean or to kill cells remaining at the end of primary debulking surgery, but unfortunately currently we do not have level 1 or even level 2 evidence to support this practice. So I don't know, many times in biology we have seen that logic may fail, although it seems quite logical. So currently the evidence we have is in the form of small retrospective series or prospective single center series, which also have contradictory results. They don't always show benefit with the addition of HIPEC. As a result, actually, none of international guidelines, HIPEC is included in primary cytoreductive setting. That's the question of this debate, actually. Primary debulking surgery, when you achieve optimal cytoreduction in stage 3 diseases, then the role of adding HIPEC. I would say currently there is no evidence to support this practice, and none of the guidelines include this. Of course, we have to wait for OV HIPEC 2 trial results to come, and earliest we expect is by 2026 or 20, if things go well. So until then, I would say it is experimental and should not be practiced outside a clinical context. So that's my take in the setting of primary debulking surgery. So HIPEC cannot be considered current standard of care unless we get more evidence. Thank you.
Thank you so much, ma'am, for your final comments and our takeaways. I'll now hand over the session to our next moderator, Dr. Neha Kakkar, for the next gray zone.
Dr. Neha, are you there?
I'm sorry. Good evening, all. So the next topic for discussion in the gray zone session is upfront inoperable abdomen confined stage 4B endometrial cancer with good response to neoadjuvant chemotherapy. So what are the treatment options further? Cytoreductive surgery or radiation? Let us have a brief discussion for now on it. Please choose your options and don't forget to submit it. Good response to neoadjuvant chemotherapy in abdomen confined stage 4B endometrial cancer. So the pre-discussion poll results are 68% will go for cytoreductive surgery and 32% for radiation. Now I will like to invite first discussant Dr. Kanika Sood to discuss the role of radiation in this scenario. Dr. Kanika Sood, she is a director radiation oncology in Dharamshila Narayana Super Specialty Hospital, Delhi NCR. Over to you, madam, Dr. Kanika.
Thank you for the kind introduction, and I congratulate the organizers for such a unique concept of gray zones. I think I got 3-4 more gray hair reading about this topic. So I hope my slides are visible to you.
Yes,
No, ma'am, please share again.
No, you have to share your slides, ma'am.
Yeah,
Yes,
it's not visible.
visible.
Right. Okay. Thank you. So many times we get references for these patients. The reference usually comes in as, why don't you give a consolidation? RT patient has received such a wonderful response to chemotherapy. So we always in radiation are challenged by this question that whether we should be treating endometrium with definitive RT. And this particular subgroup falls into that purview where the patient has been deemed inoperable by our colleagues because of tumor-related factors. Here it's being the distant metastasis at the time of presentation. Yes, radiation therapy has been used in varying combinations as definitive therapy in early stage disease. It has been used for preoperative settings in locally advanced disease and even in palliation. But the role in this particular subgroup, I would say, is not very clearly demarked. When it comes to stage 4B, post-NSCT, the query always remains. But the interest of GOG has been there in stage 4 endometrial cancers also, and they have tried to put it into the purview of curative diseases. And if you see, there have been studies way back, the GOG 9908, which enrolled stage 4 patients who had been even staged surgically. After that, they tried to take these patients after a chemotherapy regimen into a whole abdominal radiation and a para-aortic and nodal boost. But somehow, despite the fact that these initial studies did not show the toxicity profile to be on the worst side, but it did not interest for further studies because we started to have multi-agent good systemic therapies, which would take into account the stage 4 disease. But there are so many studies from way back from 1947 where radiation has been used as an alternative to the surgery where the patient has been deemed inoperable. To look at this particular chart, which is basically looking at those patients who have been treated with definitive radiation with a combination of external radiation as well as brachy, almost 5 to 6 studies in this particular group have included patients from stage 4 also. And they have shown a 5-year disease-free survival ranging from 12 months to almost 12 to 49% at 5 years, which is surprising, though it's a retrospective study. These are older studies, I would say. They are heterogeneous and had 2D techniques, but they did prove that radiation is an effective alternative to surgery, and the efficacy of LDR as well as HDR both is there when it is combined with EBRT. One good systematic review which came in 2016 on behalf of the EORT-CGCG group also had a huge number of patients, of which almost 5 studies had patients from stage 4. This particular study did establish that the grade 3 toxicities, irrespective of addition of EBRT or brachy in this particular subgroup, did not lead to toxicities more than 4%. They also concluded that radiation is an alternative to surgery with a good tumor control, and they reported a combined 5-year DSS of 78.5%. But I would say we are plagued with the differential outcome stage-wise. I would say that is a shortcoming of this review because they haven't divided the results as per the stage. It's a combined group which they have put forward. So if we talk of cytoreductive surgery, yes, we know it is a good option. The survival it offers, again, ranges from 18 to almost 40 months. But there are certain parameters which have to be taken into account. It has to be a successful cytoreduction in terms of complete cytoreduction, and also your criteria to choose the patient is limited. You try to take the younger patients, good PS patients, and with a good tumor biology, which somehow does not plague radiation that much. Another thing which has come in that in the last 2 years, we are more image guided. So the brachytherapy for endometrium has evolved. From the crude ones, we have customized applicators, the Heyman applicators, the Y-shaped applicators, which have shown improvement in local control in the subgroup. And we have very well-defined CTV image-guided delineation, MR-based brachytherapy for endometrial cancer, which has improved the local controls further on. So this integration with this will further definitely help us to be more equating towards the CRS in the near coming future. So what does the holy NCCN say? Yes, NCCN says it yet needs to be defined what would be the optimum therapy for this particular subgroup of stage 4. But they have taken stage 4 into 2. One which could have been suitable for surgery but had distant metastasis, the treatment should be systemic therapy followed by EBRT or SBRT to those oligometastasis. Palliative surgery may be considered. If it wasn't a suitable candidate for surgery upfront and had distant metastasis, treatment is systemic therapy and then reevaluation, that situation we have here for either surgery or RT. The discussion usually is commending towards adding a systemic therapy as a mainstay of treatment and then following it up with EBRT or brachy. So what I could say as a conclusion is that primary radiation in medically unresectable endometrial cancer has shown benefits. So it may be offered in our patient who is a stage 4B endometrial cancer, who has shown a very good response to chemotherapy. Because radiation, we don't know the age of this patient, but can be offered to the elderly patients as well as the ones with comorbidities. And a comment here is that we will not be giving whole abdominal radiation, which is now not thought to be the tumor-directed RT for these patients. Now, the tumor-directed RT is the pelvic radiation or extended pelvic radiation, if it is chosen to be the treatment of choice for this particular patient. So I thank you so much, and I hand it over back to the organizers. I hope I'm well within 4 minutes.
Thank you, ma'am. Now I'll invite Dr. Vinota Thomas. She is the Associate Professor of the Gynae Department, CMC Vellore. She will discuss the surgery part for the clinical scenario. Dr. Vinota.
Thank you. Can you see my screen?
Yes, ma'am.
Yes, ma'am. We can see
Thank
the
you.
slides.
I'd like to, at the outset, good evening, and I'd like to thank the organizers for giving me this opportunity. I would like to speak for the motion, the role of cytoreductive surgery in a patient who's initially inoperable with abdomen confined stage 4B endometrial cancer, now post neoadjuvant chemotherapy with good response. Now we know that stage 4B endometrial cancer does not behave so well as stage 3C ovarian cancer, among whom 75% of them actually respond to therapy. And in fact, stage 4B endometrial cancer fare poorer than ovarian cancer stage 3C. But then the role of cytoreductive surgery has been shown to have some benefit, and it's been supported by meta-analysis of 14 retrospective studies by Barlin and Bristow et al., who've shown that complete surgical cytoreduction in patients with advanced or recurrent endometrial cancer is associated with superior overall survival outcome. We can extrapolate the same in a neoadjuvant setting in select patients with advanced disease not suitable for upfront cytoreduction, especially in patients with serous carcinoma of the endometrium who have propensity to intraperitoneal spread. At the outset, I would like to talk about evidence which support its feasibility and the fact that complete cytoreduction can be achieved safely in these group of patients who are initially deemed inoperable, and also to support the fact that interval cytoreduction does have an acceptable oncologic outcome. The first point, now cytoreductive surgery following neoadjuvant chemo and endometrial cancer is feasible and safe. In this systematic review by Rabinovich et al., the most common protocol followed in these retrospective studies was paclitaxel and carboplatin. though a small proportion of them did progress, 70 to 80% of them responded to the chemotherapy given in the neoadjuvant setting, and the post-op complication rate was acceptable. Grade 3 to grade 4 complication was in the range of 1.7 to 4%. The largest data set is from a retrospective multi-institutional study from Japan, which showed that patients who had interval surgery following neoadjuvant chemo, the surgery was as complex in the primary setting, but then complete clearance was much better than the patients who had primary surgery, though it's not statistically significant. What we need to note is that a majority of them, about 54% of them, had extra abdominal disease. Though the complexity of the surgery was similar, optimal cytoreductive rates were higher, but not statistically significant. But then can the benefit of complete cytoreductive surgery from a primary setting be extrapolated to an interval setting? The same data set showed median overall survival in the interval setting similar to that of patients who had in an upfront setting of about 21 months, but patients who had no surgery at all had very poor survival outcome with a median OS of 7 months. But then before we choose patients to have surgery in interval setting, we should realize that about 10% of them can progress and about 10 to 15% of them can be still inoperable after neoadjuvant chemo, and those patients will probably be chosen for radiation therapy. Now, the SEER database has shown similar survival outcome in both groups, and they've shown a greater uptake of interval cytoreductive surgery over the past few years. So I'd like to conclude that neoadjuvant interval cytoreductive surgery following neoadjuvant chemo on stage 4B endometrial cancer is a glimmer of hope for those who are unfit for primary cytoreductive surgery, and probably preoperative imaging and laparoscopic assessment of the disease can help choose patients for cytoreductive surgery in an interval setting. But the need of the hour is prospective evidence in neoadjuvant chemo in endometrial cancer. With regard to cytoreductive surgery versus radiation, the role of radiation in stage 4B endometrial cancer is probably palliative in intent, and it's not in the absence of surgical clearance. And retrospective evidence so far supports neoadjuvant chemotherapy followed by cytoreductive surgery. I'd like to conclude, choose wisely and choose rightly. Thank you.
Thank you, Dr. Vinoda. Now we will have the post-discussion poll to see any changes in the opinion of the delegates after listening to the discussants. Please choose your option. We'll go for cytoreductive surgery or radiation. And kindly submit it.
Hello.
So now 88% of the delegates will go for cytoreductive surgery and 13% will go for radiation after neoadjuvant chemotherapy in inoperable abdominal confined stage 4B endometrial cancer. Now, I would like to invite our expert, Dr. Lata Chaturvedula. She is professor and head of department of Gynaecology, Jipmer, Pondicherry. Welcome, ma'am. Over to you now.
Thank you. And first of all, at the outset, I would like to thank Dr. Manas Biswas and team for giving me this opportunity. And congratulations both Dr. Kanika and Vinoda. I think Vinoda has sort of won the match, I would say, because definitely, though earlier endometrial cancer, in this stage, we always used to treat with radiation, but with neoadjuvant chemotherapy and when it is surgically possible, I feel, of course, like Vinita has already said, we need to choose our patients properly, like in ovarian tumor where there is a good response and we always assess following neoadjuvant chemotherapy, we always assess using imaging. And if we think it is definitely feasible, I think surgery would definitely be a better option. Of course, we can't say 100%, as she's already told, because as she said, almost 25 to 30% may require post-op radiation. That means patients will have to have all the 3 modalities of treatment. So again, we need to choose properly and then decide whether surgery would be enough following chemotherapy, which I think is a promising thing nowadays with paclitaxel and carboplatin being good results. Nowadays, of course, these trials have been done in very few centers. I wonder, in India, we have hardly done this. Maybe we should start doing and then see in most of the centers as a trial all over the country. Then we would see that how good the response would be, and then we could switch over. But then radiation has its role, especially in patients who are not fit for surgery or having other things. Still, radiation has a very good chance. So we have to choose our patients properly, not just saying surgery is the best or radiation is the best. That's what I would say. Thank you.
Thank you, madam. And I thank all the respected faculty for this wonderful session. Now, I would like to invite Dr. Sandeep Batra to moderate the next session. Sir is Director Medical Oncology, Max Institute, Delhi. Over to you, sir. Dr. Sandeep Batra.
So please unmute.
Dr. Sandeep, please unmute yourself.
I've just called him. He's on another call. Maybe.
So, okay. So in interest of time, I will just carry on with the question. The gray zone now is that patients with recurrent or metastatic endometrial cancer after platinum failure, is immunotherapy the way forward? Kindly vote for always, never, or you would use a biomarker to choose the therapy. Kindly click on your option and submit. So can we have the results, please? So 83% of the voting faculty has said that they will use a biomarker to decide onto the therapy. Now for the first session, I would like to invite Dr. Udip Maheshwari, who is a consultant medical oncologist at OncoCare Center, Ghatakopur and Sion. Over to you, Dr. Udip.
Hi, good evening, everyone. Can I share my screen?
Yes, sir, you can share.
Dr. Udip, please unmute yourself.
I am on unmute.
Yes, you're audible.
I am audible now?
You're still not audible.
Madam,
is audible.
I'm already on
unmute.
I'm on unmute only.
He's audible, ma'am.
Sure. Can I start? Yeah. So
yes, sir. Yes.
So I would be speaking for the motion. In the motion is recurrent metastatic endometrial cancer after platinum failure. Is immunotherapy the way forward? Right. So endometrial cancer, as we all know, is the most common cancer in women in developed countries. The incidence rate has increased by 1.3% every year from 2007 to 2016. Approximately 20 to 25% patients are metastatic or recurrent metastatic. However, the survival in these patients is very dismal, 5 years OS being 15 to 20% only, and that sets the stage for therapy development and future trials. So current non-immunotherapy options that we see in endometrial cancers are endocrine therapy, cytotoxic chemotherapy, everolimus plus endocrine therapy is another option that is available, and anti-HER2 therapy to a certain extent that is available. Now, if we see the responses to these therapies overall are pretty much bleak. Hormonal therapy has 20 to 35% response rates. Triplet chemotherapy has a OS of has a response rate of around 55%. Doublet will have 34. Single drug will have around 20 to 25% chemotherapy. So for OS the range is around 12 to 6, was around 12 to 16 months prior to immunotherapy. PFS ranges were around from 5 to 8 months prior to immunotherapy. Overall, there are 15 to 20% of patients who are very chemorefractory biology, and we see them daily in practice, where a patient who is refractory to chemotherapy in endometrium and on chemotherapy progressions are very common. So to all those people who say gold standard is chemotherapy, old is gold, I would say to all these people that have you ever seen the equity market recently? You know, forget gold. Gold is old is the new saying. That is what they say now. So for sure, equity market of oncology is one and only immunotherapy. So discussing prior to shifting to immunotherapy discussions, let us just understand the molecular landscape of endometrial cancer that sets the stage for immunotherapy in endometrial cancer. Is the recent TCGA classification, where they are divided into 4 parts. One is pole ultramutated, one is MSI hypermutated, one is copy number low, and one is copy number high. So all of these mutations that are seen in type 1 and type 2 endometrial cancers. So if we see the MSI and microsatellite instability part is seen in around 20 to 45% patients in type 1 endometrial cancer, which is very high. So if we see the modern classification, the pole ultramutated has the best outcomes. MSI hypermutated and copy number low have intermediate outcomes, and copy number high has the copy number low has the high has the lowest outcomes. So if we see why this is important, is that MSI being a biomarker for immunotherapy in various other cancers, it is a very important marker in uterine corpus endometrial cancers, as MSI percentage of MSI high patients are the highest in endometrial cancer, around 28.3%, versus if you see all other cancers, they are lowest. So 28.3% have MSI high. And rationale for immunotherapy in these is obviously it is self-explanatory that MSI-H have 7-fold higher number of neoantigens compared with MSS, and amongst MSS patients also there are 16% who may have a positivity for PD-L1. So proof of concept was provided by pembrolizumab, wherein pembrolizumab showed in Keynote 016 a ORR of 71%, and especially in patients who had endometrial cancer and who had MSI-H, there was a 36% response rate. And this gave agnostic, and 2017 there was a pooled approval for tissue agnostic site approval for pembrolizumab in MSI high tumors. Similarly, MSI high tumors were selected and treated in this Keynote 158 trial, and if you see most of the patients have been below the 0 line, and there is a good reduction and good response. Coming to the newest molecule that has been approved recently in April.
Dr. Udip, you will have to conclude, sorry.
Yes, so dostarlimab and other avelumab and durvalumab are the tumors that usually help. And lastly, last 2-3 slides, copy number low and copy number high mutations are the ones which are refractory. And what do we do with these? The answer is again immunotherapy. We go with immunotherapy that is pembrolizumab plus lenvatinib, which shows an overall response rate of around 40.23%, and that has been shown to have a recent approval. Other trials that are in contention are nivolumab, cabozantinib, and other combinations, chemo plus immuno combinations are there. So to conclude, immunotherapy is the way forward for endometrial cancer. As single agent as well as in combination seems to be the way forward. There are 15% patients who are chemo refractory, and these patients benefit with pembro plus lenva. So using these drugs at an earlier time interval in natural history of the disease proves beneficial and saves life. So where do we go? I am sure everyone knows the answer, and road ahead is full of possibilities. We just need to keep our eyes and mind open to possibilities. Thank you so much.
Thank you so much, Dr. Udip.
Yeah, Dr. Charu, sorry for the group up. I'm back. So if you allow, I can carry forward the things further.
Please take over.
Yeah, thank you, Dr. Udip. And we will quickly forward to Dr. Venkatapati Babu from Tejpur on what he has to say about the role of immunotherapy after the platinum failure in the endometrial cancer. And once Dr. Pradeep Babu has delivered his talk about this, we will further hear from the experts that what is the final verdict. So may I request Dr. Venkata Pradeep Babu to start his discussion about the role of immunotherapy in platinum-resistant or relapsed endometrial cancers.
Thank you, sir. Kindly, organizers, kindly allow me to share the screen, please.
Yes, sir. Allowed.
Yeah, thank you. So for a moment, I am also very much convinced about the immunotherapy when hearing said by Dr. Udip Maheshwari from Mumbai, who is very good at selling his version of facts. So let us see the reality, the ground level reality. So going forward, the question, today's topic is immunotherapy is the only way forward? It is the topic. Coming to the advanced endometrial cancer, we know that 5 years survival rates are less than 20%. And these are the NCCN guidelines, which defines the immunotherapy based upon biomarker specific, MSI high or MSS. So now the question is immunotherapy a way forward? Yes, a big yes, and definitely yes. And the other question is immunotherapy the only way forward? No, and definitely no. Why? Because there are so many targeted therapies that are evolving better than immunotherapy, and we know that the cancers that are addicted to driver mutations, they respond to target therapies much better than immuno. We have evidence from other cancers. As of now, the incidence of these mutations are very less, but we have HER2 and NTRK already we have, and there are certain histologies which have a hormone therapies that are possible in advanced endometrial cancer with a impressive response rates. And NGS, we have other option where we can find the other mutations. And re-challenge of chemotherapy, definitely a golden option. Gold can never be old. Gold is gold standard always. Let's see. So either data compelling in endometrial cancer prescribe, and can we adopt it, this costly therapy as a lone modality is the question today. Not really. Why? Because let us see the approvals in endometrial cancer. If we see the approval is TMB greater than 10, Pembro, MSI high, Pembro or dostarlimab, and MSS, it is Pembro in combination with lenvatinib. Please note here, it is not Pembro alone, it is with lenvatinib. So my friend has conveniently explained about the response rates and has forgot about the number of patients in the tumor in the trial. In the TMB biomarker study, it is 15 patients. Please see the number of patients in the entire trial. And in this study with endometrial cancer, where MSI high is approved, it is 9 in phase 2 and 49 patients in the phase 2 study. And we are seeing overall and PFS in this data, and there is no OS data as of now. Only 13 to 30% of patients, we should note that they are MSI high. For all the hype CPIs are created, it comes to mind, are we searching for the drugs for the indication or searching indication for the drugs after early approvals? Why this is a concern? Because recently we know that there are lots of withdrawals. And this is really concern because we have already counseled the patient for immunotherapy, and there are trials with immunotherapy going on, and suddenly FDA withdraws the approval, and we are in a dicey situation. So with such a small numbers and accelerated approval, it is not really a good option, because we know that even in chemotherapy, if we believe the immuno data, if this we can see that paclitaxel plus bev, it is impressive PFS 20 months and a median OS of 56 months in a recurrent setting, and response rate is 87.5. In endometrioid histology, everolimus letrozole, response rate is 32%, not bad for the cost if we see. So incidence of MSI is 30%. What about 70% of cases who are MSS? Because can immuno act alone? Definitely not. We have to combine with lenvatinib, which is the current approval, because it acts at various levels and modulates the tumor microenvironment. Immuno alone cannot act, and we are not at a position of understanding of molecular biology of cancer that immunotherapy are strong enough to be prescribed alone. Even if we see the ongoing trials, there are several molecules in combination only, not immuno alone, particularly in MSS patients. So if we see the real world data, practicability of usage of immuno usage in India, it is very different from the apex academic institutions and super corporates serving to a different set of society and the ground from the ground reality of the majority of cancer patients. So the question is the only forward is the immunotherapy? No, it is my perspective. Why? Because this is the real world survey that is done in Indian medical oncologist, who has said that less than 5% of patients are affordable for the immunotherapy in their practice. And the reason for not prescribing, not using immunotherapy in the indicated patients is lack of affordability seen in 95.4% of patients. So Udip may say it is a purely academic discussion, but frankly speaking, there is no pure academic discussion without financial education. Even in ESMO, ongoing ESMO, it is the MCBS which we see. So except pure academic discussion can go in Sultanate of Brunei because there is no depth of money. So my options apart from immuno are rechallenge of platinum in selected patients, hormone treatment in selected histologies, and combination is the way to go and not a standalone immuno. So my conclusion is our understanding of immuno, it is still imperfect at this point of time. We need a better understanding of molecular biology. Maybe CAR T cells, cancer vaccines are the future. Then we may use immunotherapy alone. Till now, combination therapies along with some targeted therapies or chemotherapies are the way to go. Thank you so much.
Thank you, Dr. Venkata. You made your point very well. Listening to both of you, I was very clear what to do and not to do, but I'm a little bit confused. Let's now go for the survey to find out whether the other panelists and the attendees, they have got the answer, or they still want a perfect expert to step in to deliver the final verdict. So you have next 30 seconds to submit your post-poll response. Okay, so it's a divided house. It was a divided house, but now it says biomarker directed therapy and immunotherapy we know works better when we have a biomarker. Let's now move on to the expert delivering the final verdict, and we have none other than Dr. Sudeep Gupta. He is the professor of medical oncology and director ACTREC. It is really mesmerizing to listen to him when he orates, and he orates very well. And when you listen to the academic talk he gives, especially on the breast cancer, gynae cancer, or any other cancer, it really mesmerizes. So let's move on to Dr. Sudeep Gupta to deliver the final verdict about the role of immunotherapy in endometrial cancers after the platinum have failed. Dr. Sudeep Gupta, sir, please.
Thank you, Dr. Batra, for your kind introduction, and thank you to the organizers for inviting me. Both the speakers made their points very well. And since you talked about me delivering the verdict, let me say that the jury is hung. There is no one clear-cut answer to the question. In a debate, both parties have to, of necessity, take extreme positions to make their point, but the truth, as usual, is somewhere in between. So we know that the outcome of patients who have failed previous chemotherapy in the metastatic setting is not very good. The response rates as well as the survival is variable, but in general is not very good. And immunotherapy, especially the immune checkpoint inhibitors, have made a contribution in at least some of the cases. And the point was well made that most of the benefit has been in patients who have MMR deficient or MSI high disease. But we also have the combination of an immune checkpoint inhibitor with lenvatinib, which now in a large randomized trial, the Keynote 775, has proved an overall survival benefit versus a treatment of physician choice chemotherapy. We know that this is a very toxic regimen, and of course, it is not financially feasible for most of our patients, but nevertheless, it is a valid option. So I think immunotherapy is one of the appropriate choices in some of the patients, and I agree with the audience that we should not use it in every single patient. Perhaps to get the most bang out of the buck, our treatment needs to be biomarker directed, and the biomarker that is most promising here is, at least in the context of immunotherapy, is MMR. And of course, we have the estrogen receptor, the PI3K abnormalities, and HER2 for other treatments as well. So I was very gratified listening to both the speakers, and they made their points very well. Immunotherapy is one of the choices in this situation, and an appropriate choice in some patients, but definitely not in all patients. Thank you.
Thank you, Sudeep sir, for summarizing it for all of us. So it is see the target, hit the target, you shoot an arrow, you miss the target. So with this, I will hand over the baton of the next gray zone to Dr. Abhishek. Dr. Abhishek Gulia, please carry forward the next grade role discussion about the adjuvant treatment in the endometrial cancers. Over to you, Abhishek.
Good evening, everybody, and thank you, Dr. Batra. So this session is about the adjuvant treatment in 1B endometrial cancer. And endometrial cancer, as we all know, a lot has been going on in the recent past with molecular classification coming up, and there are various guidelines which are in early endometrial cancer are not sometimes on the same page. So I'll request all the participants to vote on the question: do age, LUS, and tumor size dictate the adjuvant treatment in stage 1B endometrial cancer? You have to choose between yes and no and can't say. And I request everybody to click submit button after they have made their choice. All right, so we have the results of the opinion poll, and most of the, not most, but 62% of the participants feel they do matter as far as choosing the adjuvant treatment is concerned. For shedding more light on this, we have the first discussant. She'll be speaking in the favor of motion. She is Dr. Shikha Goel. She's a product of AIMS and currently in PGI Chandigarh. Dr. Shikha, a radiation oncologist. Over to you, please.
Thank you, Dr. Abhishek. I'm sorry. Are my slides visible?
Yeah, they are. You're audible. Yes.
So I'm speaking in favor of this question. We know that 1B endometrial cancer is also a heterogeneous group composed of various grades, presence or absence of LVSI, and so on and so forth. So this is also divided into various risk categories. It could be high-risk disease in high-grade tumors where adjuvant therapy cannot be omitted. Whereas in intermediate risk, we have subcategories of low and high intermediate risk, where we may opt to de-intensify therapy to minimize toxicity or intensify to reduce the possibility of recurrence. And different adjuvant modalities may have different efficacies or side effect profiles. Traditionally, the risk factors that are defined in the prospective trials have been age, grade, and LVSI, apart from the depth of invasion that is used to define the stage as well. So the initial key trials were the POTEC trial and the GOG 99 trials. Both have defined their high intermediate group as patients depending on age. The POTEC trial took patients more than 60 years of age with either 1B or grade 3, but never both. GOG 99 used 3 risk factors of grade, LVSI, and myometrial invasion. And if the age was more than 70 years, 1 risk factor was enough to classify it as high intermediate. If age was between 50 and 70, 2 risk factors were needed. For younger age groups, all 3 risk factors were needed. So coming to the data which defines the role of age in deciding treatment, the first trial was the Norwegian trial, which used DH-BSO followed by brachytherapy, and then randomized patients to no further therapy or pelvic radiotherapy. It was the first trial which showed that pelvic radiation did reduce vaginal or pelvic failures in high-risk disease. The major proportion of women who were more than 60 years had 1B disease, and irrespective of the arm chosen, the patients who were older than 60 years did not do as well. They had higher recurrences and higher deaths. The 20-year update came about 7 years back, and there also patients who were under 60 years but received EBRT did poorly. They had high risk of second cancers as well as a lower overall survival. So this trial gave us the information that age is prognostic for this group, and unnecessary EBRT in young age may be hazardous. Coming to the POTEC trials, there also the majority of patients, nearly 3/4 of the patients were more than 60 years of age, and age was a significant factor both for locoregional recurrence as well as cancer death risk, with a hazard ratio of more than 3. We can compare the hazard ratio of locoregional recurrence for age, which is more than 3.2, and for grade 3, which is traditionally known as a high risk factor, where the hazard ratio is only 2.2. So this trial defined that for patients who are more than 60 years of age, adjuvant RT reduces the risk of locoregional relapse, whereas for patients who are younger than 60 years and grade 1 and 2, adjuvant radiotherapy is not needed. And POTEC 2 replaced external beam with brachytherapy and showed better quality of life with that. So RT in older age does reduce recurrences in grade 1 and 2 1B disease. GOG 99, as I said, it defined the high intermediate risk group, which was responsible for nearly 2/3 of recurrences and cancer deaths. And the high intermediate risk group, this was defined by age, and EBRT in this group reduced the recurrence probability by nearly 18%. There are some trials which have tried to compare EBRT with chemo alone or chemo and radiation therapy in intermediate high-risk groups. I will not delve into the results of those trials, but be aware that all of these trials have shown age as a significant prognostic factor. And the POTEC trial, which is exploring the role of molecular integrated risk profiles, is also incorporating age as a factor. Several nomograms have used risk stratification based on age. Coming to the next factor of low uterine segment, we know that lower uterine segment has a thinner myometrium than the rest of the uterus, and it is difficult to measure depth of invasion there. So it's an independent prognostic factor for death and distant disease, but there are no randomized trials which have reported on adjuvant therapy with documented LUS involvement. It has a worse prognosis, there is worse PFS and worse OS, but whether it defines treatment is not very clear. Similarly, for tumor size, a large tumor volume either on MRI or on pathology does correlate with higher grade of disease, higher risk of invasion, as well as higher lymph node positivity. But whether or not a higher tumor size define higher local recurrences, thereby meaning more adjuvant therapy needs to be added, is not very clear. So several guidelines have devised this. Only the NCCN defines depth, tumor volume, and LUS invasion, whereas all the guidelines use age as a defining factor for their risk stratification. So concluding, the molecular-based risk stratifications are they are promising, but validation is not yet done. The traditional risk factors will remain, but all of these risk factors, whether it is the depth or grade or LBSI, are dependent on the observer. So when there is confusion in these risk factors, the other factors that I have elucidated, they may be used to guide adjuvant therapy where these findings are equivocal. Age is definitely not a contentious factor. Advanced age does mean that most patients will need adjuvant radiotherapy, but the other factors may be used to decide whether surgical staging is needed or whether over observation we have to choose adjuvant therapy, especially if other risk factors are present. Thank you.
Thank you, Dr. Shikha. And speaking against the motion, we have our second discussant, Dr. Bhagya Lakshmi. She's an associate professor in Cuttack. I request to please stick to the time, ma'am, please. Yeah.
Thank you so much, the team Maxcon and Dr. Abhishek, and thank you, Shikha, for setting the stage for me. So let me share my screen. So hope I am visible now.
Yes, ma'am.
Visible? Yes. Okay. So I think actually Shikha has made my job very easy because she has in her last slide almost told that molecular profiling is the answer. So do age, LUS and tumor size dictate the adjuvant treatment in 1B? So my answer to this is clearly a no, and I think the debate should end here. But then I have to show some evidence for that. And my disclosures are that I assume that this 1B is a surgico-pathological staging which has been done completely. However, there is some missing data about the grade, the histopathology, LBSI, and all we know is that salvage radiotherapy has given equal results even after recurrence in early stages. So NCCN, again, you see 1B is a real heterogeneous group because grade 1, grade 2, 3 and 3 are heterogeneous groups. And in grade 1, again, we see that we have to give vaginal brachytherapy or consider observation if no other risk factors. And so the risk factors, as told, are about the grade, about the invasion, and about the LBSI. So, and the next thing is that potential adverse risk factor is age more than 60 years. So I think that's again a misnomer which Shikha told that 60 years is a very clear-cut thing, but that's a potential risk factor again. So then coming to the ESMO ESP 2020 guidelines, we see that in intermediate group, we have a stage 1B endometrioid with low grade with LVSI negative or focal. Negative or focal. There's no mention about age or about the LUS or about the tumor size. Similarly, in high intermediate and similarly in the high group also, where the high risk group only constitutes stage 1 non-endometrioid. And even if you have a molecular classification also along with that, still again these three factors are not taken into account. So PROTECT 2 again shows that shows that in women with high intermediate risk, the age more than 60 years, grade 3, and were randomized to pelvic radiation versus vaginal brachytherapy following HBSO without staging. The vaginal recurrence rate was 1.9% in each of the arm, and there was no difference in overall survival. And so this again shows that the total pelvic recurrences were by unfavorable risk factors. Those were LVSI, P53 mutant, and or L1CAM. So again, FIGO 2018 clearly defines the risk factors as tumor grade 3, LVSI, non-endometrioid histology, and cervical stromal involvement. So there is again no mention about those three factors. So, and again, this is a more recent meta-analysis of all the stratification models in which we can see that in the Mayo criteria, which has been modified to Mayo modified criteria, it has disregarded the tumor size. Similarly, there is no difference in the age and also the lymph node metastasis according when age was taken as a criteria, and primary tumor diameter also. Though the primary tumor diameter looks significant, but here you can see that the tumor diameter is between 3.5 and 5. It's not less than 2 or more than 2. So in 2018, again, this was a recent article in which Dr. Walter Gottlieb and all have studied that. Their results suggest that tumor location in the LUS is an independent prognostic factor. But the limitations of this study was that there was no genetic test done. Number of LUS tumors that were analyzed was limited, and somatic copy number alterations and epigenetic events were not considered. And I understand that type 2 tumors have a propensity to involve lower uterine segment. So lower uterine segment cannot be a risk factor in type 2 tumors as well. And this is a Turkish study in 550 patients in which they have shown that again there is no difference with stage 1 or stage 2 endometrioid type endometrial cancer who had a lymphadenectomy. And so this is again a study, again a Turkish study, more recent, which in 550 patients in 2017, that LUS involvement was not an independent prognostic factor for poor survival. Astro again in 2014 has set its guidelines that grade 1 or 2 tumors with more than 50% myelinvasion may also benefit from pelvic radiation to reduce pelvic recurrence in more than 60 years. So that's again a may, it's not really sure about that. So this is again a recent trial in which 448 patients showed that age is not a prognostic factor for recurrence. So this is not a risk factor. So we are looking at the rainbow refining adjuvant treatment in endometrial cancer based molecular profiling, and we are looking at the results and waiting for that to come out. So I think the answer is clear-cut. Molecular classification is the new driver. So I think for all my friends here, think again whether it's molecular profiling, grade and LVSI, or age, tumor size and LUS. Thank you very much.
Thank you, Dr. Bhagyalakshmi, for the nice talk. And can we have the second time poll? Has the talk managed to sway the opinion? I request all of you to choose your answers and don't forget to click submit button within the next 30 seconds. Yeah, can I have the results, please? All right, so the talk has really made a difference. And now 71% of the participants feel the age and LUS and tumor size don't dictate the adjuvant treatment. Can we have some expert comments by our expert, Dr. Neeraj Rastogi, Professor of Radiation Oncology at SGPGI, Lucknow. Dr. Rastogi, please.
I am thankful to Dr. Harith, Dr. Sharu, Dr. Shefali, Manas, and whole of the Max team, Dr. Abhishek as well. So I think both the speakers, Dr. Shikha and Dr. Bhagyalakshmi, both have presented the points very well. But in my opinion, if you see the age more than 60 years, usually have the more aggressive histology and advanced disease. And usually most of the time it is treated less aggressively. But if you treat these patients more aggressively, which is published in one of the trial in cancer 2003, so even the survival is poor if more than 60 years. So even in PROTECT trial as well, in which 70% of the patient were more than 60 years. So as Dr. Shikha has already shown that local recurrence rate is hazard ratio is 3.9 times. And the cancer mortality is also increased by 2.6 times. So age is definitely an important prognostic factor. But since it is the lower uterine segment may not be very important prognostic factor. In the trial, which has shown that lower uterine segment also has shown the decrease in the 5-year survival as well as disease-free survival, which is the trial which was published in Annals of Oncology. So if in one of the trial it has shown that if isthmus is positive or if lower uterine segment is involved, then the chances of the lymph node involvement is high. If the chances of the lymph node involvement is high, then it also decreases the survival. So, and the third thing is the tumor size. Tumor size more than 2 centimeter or it is involving the whole of the uterine cavity. So definitely the larger tumor size involving the whole of the uterine cavity, there's the increased chances of the recurrences as well as decrease in the overall survival. So especially the age is very important, not the rest of the lower uterine segment as well as tumor size may not be very useful. But I think in the presence of the molecular markers, maybe in future, maybe age may not be important factor that time. But at present, till date, age is a very important, rest may not be. Thank you.
Thank you, sir, for your valuable insights. And with this, we'd like to move to the next gray zone on locally advanced carcinoma cervix. And I'd like Dr. Bhuvan Chugh to please take over.
Thank you, Dr. Gulia. And I think that was a very, very well moderated session. Rather, speakers were very nice. So I think moving forward, what we want to ask is, and me being a medical oncologist, I really want to know this is there a role of consolidation chemotherapy in a locally advanced carcinoma cervix post CTRT? And so we have our pre-poll coming in, and I think we have 30 seconds, and please don't forget to press submit at the end of it. And so, you have the options of saying yes to it, saying no to it, and, obviously they can't say to it. Perfect. So I think the house is completely divided, and there could have been nothing better than that. And that really makes the, the job of the discussants a little bit more difficult than it would have been. So for the discussants, I have Dr. Rami Reddy is there, who's going to be speaking. Dr. Karuna is there, who's going to be speaking against the motion to begin with. And then we'll have Dr. Priya Tiwari, who'll be speaking for the motion. So can I invite Dr. Jeba, please? I think you are, please share your screen and please start your presentation. You have exactly 4 minutes for it.
Yes, sir. Can you just stop sharing, sir?
Yes, ma'am. Now you can share.
Yes, ma'am.
Can you see my screen, sir? Am I audible?
Yes, ma'am.
Yeah. So good evening, one and all, and thank you, organizing committee, for giving me this opportunity. I'm going to speak against the role of consolidation chemotherapy in locally advanced cervical cancer. We all know that concurrent chemoradiation is the standard of care in cervical cancer, and we have a good success rate with this treatment, and it mainly targets the local control. So as time went on, the idea to control nodal disease and to eradicate systemic metastasis was going among the clinicians and oncologists worldwide. So the idea basically of consolidation chemotherapy is to control the nodal disease, consolidate the local control, and eradicate systemic metastasis. That is the idea. but and emotion, of course. But we as physicians, as clinicians, or oncologists do not treat our patients based on our ideas or emotions, and we need to have sufficient evidence for this. So let's look quickly into the evidence. This is a retrospective study which administered paclitaxel and carboplatin after concurrent chemotherapy with pacli and carbo. Though it showed a minimal survival benefit, there was a selection bias and a small sample size and short follow-up. Then from retrospective stage, some clinicians moved on to perform phase 2 studies, which were published in Red Journal in 2007 and 2010, which predominantly demonstrated the tolerance and the feasibility of consolidation chemo, but not efficacy. This is also one such phase 2 study where they administered paclitaxel and carboplatin after the standard chemo-RT, and they said it failed to improve PFS and OS outcomes. All the stages were 2B, 3A, and 4A. Then we move on to the next phase 3 randomized study comparing concurrent gemcitabine plus cisplatin followed by gemcitabine and cisplatin versus the standard treatment. This was one of the most popular trials when it came out in JCO in 2011. Though this study demonstrated PFS benefit, we have to take a look at this grade 3 and grade 4 hematologic as well as non-hematologic toxicities in the intervention arm. And there were many discontinuations in arm A, and we are not really sure whether this response is due to the concurrent chemotherapy which was administered, that is gemcitabine and cisplatin. And this is then came one more randomized controlled trial comparing the standard treatment versus standard treatment plus adjuvant chemotherapy, where they administered paclitaxel and carboplatin, and this study significantly said that this regimen or this intervention did not improve response rate and survival when compared to CCRT alone. Though they made a comment that the systemic recurrences are more in the standard arm, if you really look at the numbers, there's a very, very, very trivial difference between both the arms. So this intervention regimen did really not make a difference in the outcomes of these patients. And then came our most awaited long-term Outback trial, which I was also looking forward to listen to. This is a well-conducted trial and a huge sample size where they randomized into 2 arms. One arm, the standard concurrent cisplatin plus EBRT and brachytherapy arm versus the standard treatment plus adjuvant chemotherapy, where they administered 4 cycles of paclitaxel and carboplatin. The median follow-up was 60 months, and they clearly said that adjuvant chemotherapy given after standard cisplatin-based chemo-RT did not improve overall survival and PFS. So coming to my discussion points, maybe the earlier studies which seem to have benefit are retrospective, and there is a selection bias where clinicians choose to give chemo in some patients and did not choose to give chemo in some other patients. And I also pointed out to the poor methodology. And if you see the concurrent chemotherapy, the regimens were quite complex, gemcitabine based, paclitaxel, carboplatin based, which are really not practical in our population. And as you all know, there is no benefit proved in randomized phase 3 trial. And as you all know, cervical cancer is a disease of almost low socioeconomic status where logistics and finances are a major issue. And why do all these patients need to go through this toxicity when there is really no proven benefit? So conclusion is there is no evidence of consolidation or adjuvant chemotherapy in cervical cancer after standard chemo-RT as per the existing evidence. So concurrent chemo-RT is the standard of care in locally advanced cervical cancer, and I would suggest and recommend to implement image-based treatment both in EBRT as well as brachytherapy as far as possible. Thank you.
Sir, please unmute.
No, unmute session. I think it's your turn to speak for the motion. I guess please go ahead.
Good evening, everybody. I'll be just sharing my screen. Is it visible?
Yes, please.
Yes. So a very interesting topic, and I'll be talking for the motion consolidation chemotherapy role after CTRT. So stage 2B to 4A is usually taken as locally advanced disease, but now, yes, more and more trials and studies are also including 1B onwards. Now, the problem is consolidation chemotherapy after CTRT, as far as the guidelines are concerned, are not a standard practice. More so because, as already pointed out, there is lack of properly conducted randomized controlled trial to answer the question. We do have one trial now, but yes, the main problem with cervical cancer, especially with the locally advanced diseases, we do know a subset of patients will have systemic relapses. For all the locally advanced cancer across all other cancers, we know that there is a role of systemic therapy to prevent systemic relapses, but unfortunately, the results have yet not been replicated in the cervical cancer. And we are unfortunately losing patients because this is one area which needs to be further worked upon. So as already pointed out, this was a very interesting study and it actually put the way forward, a phase 3 open label randomized study, which had a combination of gemcitabine and cisplatin. So as results already pointed out, the PFS at 3 years were actually significantly improved after the combination of gemcitabine in both the CTRT arm as well as the ACT arm. And also overall survival benefit was there, but yes, at the cost of increased toxicity. So what the results are trying to tell you that yes, there is a scope of improving the results, but you have to find the best combination as well as the best timings. Now, when you start adjuvant chemotherapy after radiation therapy, it's very important that you let the side effects of radiation therapy subside. The trials which have shown less toxicity have usually started the adjuvant chemotherapy after 4 to 6 weeks of the completion of radiation therapy. So the timing needs to be taken into consideration. This study showed a subgroup analysis that the patient with stage 3 and 4A, mind you, this is the group which actually has a lot of recurrences. This is actually decreasing your survival rates. And here there is no particular trial just addressing this particular subgroup. So here the subgroup analysis showed that the patient with stage 3, 4A, tumor more than 5 centimeter and of non-adenocarcinoma histopathological subtype benefited more from the adjuvant treatment. Now there were two very important meta-analyses. This was one of the older meta-analysis. The idea was to compare, to see the effect of chemotherapy in combination to radiation therapy, but it also pointed out a larger survival benefit with the two trials in which chemotherapy was administered after chemoradiation. And if you want to see the figures, absolute improvement of 19% at 5 years and also visible from this particular graph where you see the best results where the CTRT was followed by chemotherapy. Another meta-analysis, a more recent one with the adjuvant systemic therapy after chemoradiation. Now, the problem was, again, as already pointed out, that a lot of trials are there, but they are not properly randomized trials. Now, this was a meta-analysis of 12 study on 2 chemotherapy doublets, platinum taxanes and the platinum pyrimidine antagonist. They did not show any significant overall survival benefit. Now, the problem with doing a trial of adjuvant chemotherapy is we know that when you are giving adjuvant chemotherapy, when the disease comes back, then there is already some other treatment going on. So the patient might not have an overall survival benefit always. So what is important is a distance metastatic free survival should be one of the important endpoints. But unfortunately, those kinds of endpoints are actually not being seen in the cervical cancer. The 2 randomized controlled trial which were included in this particular analysis, they did show a significant benefit for the distant metastatic free survival. But yes, we need adequately powered high quality randomized controlled trial. And Outback was one of them. It did show that there was not much difference when you talk about OS and PFS. But what is very important is that we are talking about a high risk group where we feel that the treatment for adjuvant chemotherapy is warranted. And somehow this trial was quite heterogeneous in the trial population. You had patients from 1B, 2B, 3B, 4A. So you see that it actually does not address that we should be given in higher risk or not. And
Dr.
similarly,
the time we'll have to consider that time, and it's a head-on thing.
Okay,
Anyway,
so there's just adjuvant chemotherapy adherence was also on the lower side. So all these factors should be taken into account, that no trial to address high-risk population specifically. And that is what we lack in a cervical cancer. So adjuvant therapy is a promising approach, but we need to find subgroup where risk-benefit ratio is justified. Timing and regimen needs to be researched. And existing trials have a problem of being heterogeneous, small sample size, and inadequately powered. Adjuvant chemotherapy has a potential to improve efficacy and merits further research. So that's all.
Thank you both the speakers, and thank you. I think it was very concise and very comprehensive. And can we have the post poll, please, in the meantime? So I think we have the discussing it further. And I think what Dr. Jabi said was there is no definite evidence, and what Dr. Priya Tiwari said was let's divide locally advanced into further into 3 and 4A and look at the age. Anyway, moving forward, we have our expert. Can we have the post-poll results? So I think the House thinks that the evidence in favor of no is more than that. So I will have we'll have Dr. Rangarao sir, who's our expert panel, who was expert, and he'll give us his expert's comment about it. So sorry, the time still remains for 4 minutes for you also.
Fine. I'll make up for the time that has been lost. Thank you very much. I think very wonderful discussions by both Karunya and Priya. I think they put their points very well. And then they have summed up the whole literature. I think first thing is we must understand that the patient subgroup of all these locally advanced cervical cancers are not one single type of cancers. There are multiple subtypes. I mean, there are many, it's a heterogeneous group. And then that is one. Second thing is about 20 to 25% patients do have distant recurrences who require some kind of a treatment. And the third thing is there are some high-risk patients who definitely will have either local or systemic diseases. They also require additional treatment. And some patients do have residual disease. They also require some kind of a treatment. So we understand that there is a need to give some treatment, and then trials have now been progressed from phase 2 to phase 3 to meta-analysis to ask this question: is chemotherapy warranted at the end of the CTRT in all patients? I think the trials have very clearly said not in all patients, maybe in some. The trials have also varied in their result. They have not been consistent. Some have said there has been a decrease in the overall survival. Some have said there have been increase in the betterment of the disease, distant recurrent-free survival. So like that, they mixed results. So, but one important thing we still understand is that there is a need. Maybe in future, at the moment, the evidence does not support the giving the adjuvant chemotherapy in all patients. I would say select certain patients and then do them under observation under the clinical trial. Definitely, it's not worth giving in every patient. And the other thing is maybe in future, we will have some new things like immunotherapy or even targeted therapy to come up to the rescue of these patients. So I think we need to have better trials in the Indian setting. Unfortunately, despite having such a big load of the cervical cancers, we do not have the bulk. And I'm not sure the Western population and Indian population of the cervical cancer are the same. I would be very, very happy to see the Indian patients undergoing such trials, and then we see the things. Probably in Indian patient, the results will be somewhat different. So with this, I think I say that right now it's not a standard of care, but this does not close the chapter of investigating the adjuvant treatment post CTRT in these patients. We should look forward to more data, especially from Indian centers, and also look for the immunotherapy and other things and combination of the chemoimmunotherapy in such high-risk patients. Thank you very much and wonderful discussions. Thank you for having me at Maxcon. Thank you, Kanika. Very well organized.
Thank you, Dr. Rao. And thank you, Dr. Bhuvan, for conducting the excellent session. Now let's move on to our last session on video presentations. I would like to invite our chairpersons, Dr. G.K. Chadav. He's a senior consultant radiation oncologist at Apollo Hospital. Dr. Bhaume could not join us. And Dr. S.K. Giri, who is the head of gynec oncology at Cuttack. Dr. Giri, I would like you to invite Dr. Anupama.
Good evening, everybody. Am I audible now?
Yes, Dr. Giri.
Yeah. So it's a pleasure to invite my friend, Dr. Anupama Rajan Babu, who is a professor of gynecology, Amrita Institute of Medical Science, and she's a very good robotic surgeon and does good number of robotic radical surgery. So now, Anupa, the stage is yours.
Thank you, sir, and thank you, Dr. Manas and Dr. Kanika, for inviting me here, and congratulations on an excellent context of the Maxcon. So my slide should be visible now.
Yeah, Dr. Anupama, it's visible. Please go ahead.
Yes. So sentinel node mapping in endometrial cancer. I'll quickly go through my videos. So it's no longer a new technique. We all know what is the guideline for sentinel node mapping for endometrial cancer. All of us are, most of us are, I think, doing sentinel node mapping at some point for endometrial cancer. And for the students or for the people who are just starting sentinel node mapping is not just a technique. It is an algorithm which has to be followed. So which involves inspection for the nodes, removing any large nodes, and correctly identifying the sentinel node. And if you're not finding a sentinel node, you have to proceed with lymphadenectomy on that side. And always remember, sentinel node technique is only for normal appearing nodes. If you have any suspicious node or extrauterine disease, then that takes priority over sentinel node mapping. To start my videos, so in a robotic platform, the dye that you use is the indocyanine green dye. So indocyanine green dye has got maximum sensitivity in detecting sentinel nodes. I use a dilution of 0.5%. You can use a dilution from 0.5 to 1.25%. Now the standard injection technique, which is given high rates of success, is intracervical injection. Very easy to inject. At 3 o'clock and 9 o'clock, you inject both superficial and deep. It is not really necessary to use spinal needle to inject. I use ordinary needles for injection. Inject just submucosally and inject deeper into the cervix to get a good mapping. And once you inject, the dye immediately travels onto the uterus and to the lymph nodes. So within a few minutes, you can see the dye staining the uterus, and within less than 5 minutes, it comes into the lymph nodes as well. So here you can see the tract and the lymph nodes. And on this side, you can see the tract. You can see an obturator node. And from the obturator node, you can see that it is the dye is traveling along to the upper iliac nodes as well. So the indocyanine green has got this property. It will not stay in one node. From the first apical node, it travels to the second apical node, and it goes to the other nodes as well. Sometimes the entire chain. Here you can see that the entire chain of lymph nodes is lighted up. And in this case, you can see sometimes you see this. You can see two different sentinel tracks going from the site of injection. So for this particular patient, there are two different sentinel nodes because there are two different tracks going to two different nodes. And the sentinel gives you atypical locations also. And this is one such location, the parametrial node, which is getting lighted up with the sentinel light. And around 10% cases, we get atypical locations as well. So one important feature that you should remember is to identify the sentinel node correctly when you're using ICG. Because here you can see, as soon as I open the retroperitoneum, I see a bright node at the external iliac region. If you stop dissection at this point, you will be missing the real node, which is actually deep down in the obturator area. So here you can see that the lymphatic tract from the site of injection is going to the obturator node, and that is the sentinel node. It is very important to open up the retroperitoneum and identify which node is being drained from the site of injection. This will help you to correctly identify the sentinel node. And sometimes when you're injecting and you're looking for a sentinel node, you might not see a lymph node easily. So this is a patient where you can see that I've injected, you can see the tract clearly, but the lymph node is not seen. We see the scenario when we're using blue dye also. Sometimes you see the tract, but you don't see the node. So ICG makes it very easy for us to follow the track. So this is the advantage of ICG. You can follow the track. You can see where the track is going. And here in this case, it is a common iliac area. It is going to just at the just below the aortic bifurcation. So the contrast of ICG helps us to identify this. So it is mostly where you get to see a node in the pelvis. But if you don't get to see a node in the pelvis, always trace the track upwards, look upwards. Mostly you will find a sentinel node when you're using ICG. So this is another scenario where we have traced the lymph nodes. So when you trace the lymph nodes, here you can see the lymphatic going up. And one more point which you have to note during dissection is when you're dissecting, try to preserve the lymphatics. Once, if you cut the lymphatics, the entire ICG dye leaks into the retroperitoneum and the entire area will be stained green. The fluorescence will be there, and then at that time it will be very difficult for you to identify the lymphatic tract and the correct lymph node. You can see the common iliac bifurcation, and the tract is going under the common iliac artery. You can see a lymph node sitting just under the common iliac artery. So this is the advantage of using ICG and identifying the lymph node correctly. So the rare occasions we know there are different lymph node locations as well. We sometimes see presacral areas, we see paraortic lower and upper paraortic. This was a patient where there was the tract was directly going to the paraortic area. So a cervical injection also gives us paraortic sentinel node. So to conclude, I would say that now, from the previous discussions also, you have seen that now the sentinel node is more used in endometrial cancer, irrespective of the stratification. And now we have newer technologies. We have the open ICG detector from Stryker. We have the lab detector. Then we have technology which is much more advanced than the robotic cameras. But we still need long-term survival data. And always when you're starting sentinel node, acknowledge your learning curve. Don't straight away jump to the sentinel node mapping. Do it, validate in your center, and then practice sentinel node mapping. Thank you.
Thank you, Dr. Anupama. Would request Dr. Jadhav to introduce Dr. D.N. Sharma.
Good evening, Kanika, and good evening, all the team from Max. I would like to welcome Professor D.N. Sharma, who is a professor and head of AIMS, Radiation Oncology. And he is going to speak on MOPIT. He's going to introduce to MOPIT. MOPIT has been since here in the radiation practice for the last 3 decades or so, after Martinez developed this template, and we have been using it for all the perineal implants, the gynecological malignancies, prostate, etc. Dr. D.N. Sharma, kindly take over.
Can you see the screen, sir?
Yes, very much.
Okay, sir. Thank you very much, sir. And respected chairpersons, ladies and gentlemen, very good evening. Thank you, Maxcon and your team for inviting me and giving me the opportunity to share my, some of the skills which I have learned over years. So today I will share a video on a procedure called Martinez Universal Perineal Interstitial Template Brachytherapy. Now, this MUPIT is actually nothing else but a device used for performing the interstitial brachytherapy procedure for the pelvic malignancy. MUPIT is in fact a universal template which can be used for vulva, vagina, endometrium, anal canal, cervix, so rectum. It can be used for all the pelvic organs. So that's why it's called as a universal template. So without wasting time, I'll just share start sharing the video. Can you see the video, sir, now?
Not yet.
No.
Not yet.
Okay.
We can only see your first slide of your name.
Okay, fine. Maybe I think so. I have to unshare that and then I have to. Maybe. I think so. Can you see the screen now, sir?
No, sir.
Okay, I think then maybe I have to unshare and then somebody has to allow me to share the video, sir. Actually, I think this is.
Yeah, you can share.
Allowed, sir. Okay, allowed. Okay, fine. Now I will say. Yeah, that's right.
So anyway, we are last session, so not to worry about the time.
Okay, fine,
That's
sir.
what I think so.
Okay, fine. Thank you very much, sir. Okay. Is it visible now, sir?
Yeah,
yes, sir.
Perfect.
Okay, fine. So to begin with, patient is to be anesthetized, and the preferred approach for anesthesia is the local anesthesia, the spinal anesthesia. Nowadays, I prefer, in fact, the spinal epidural anesthesia.
Click on play in place, sir. Click on play.
Hello, sir.
Click
Can you
on
hear me?
play.
Can you hear me, sir?
Yes, sir.
Okay, fine. So we begin with the spinal anesthesia. Nowadays, I prefer spinal epidural anesthesia because then we can maintain the anesthesia if we proceed it's like lasting for 2 or 3 days. So both can be practiced. And after the spinal anesthesia, patient is made to lie down in the lithotic position. In the meantime, I'm just showing the trolley for the instruments, the Foley's catheter. As you can see, the template, 2 plates, the dilators, forceps, scissors, and the needles, screws, needle holder, and almost the same like you do for any pelvic brachy procedure. Obturator, retractors, so screws for tightening the needles, so sutures. So all these are usual instruments required for this. And we begin with the cleaning and draping. This just like any other pelvic surgery procedure, and it requires a thorough cleaning. And after that, we prepare the ultrasound probe, because if you have the transrectal ultrasound probe, the process is going to be very simple. And I always recommend the use of transrectal ultrasound for performing this procedure. Nowadays there are balloons in the market which are easy and better for visualization. But if you don't have that balloon, you can use the condom with the jelly, and then put the trilumen Foley's catheter. It's always better to put a trilumen catheter, because if there is a hematuria or some bleeding, then you can always start the irrigation. We begin with the postcalvo examination and see the, visualize the tumor, and then we perform the baseline transrectal ultrasound procedure, so that you have the orientation to the various pelvic organs and the tumor as well. Now you can see here the Foley's bulb, which makes us which helps us in identifying the bladder. As you can see, this is the bladder wall, and the urine inside the bladder. We keep it full so that you can see it clearly, and the needles do not puncture it. If you can dilate it, the upper wall of the bladder will be pushed up, and even the gut will be pushed up, And then we start putting the uterine sound so as to see the anatomy of the uterus, whether it's anteverted or retroverted. And then we put the tandem. As you can see, we put the central tandem. We must use the central tandem if possible. We should always put a tandem, because that will allow you to throw the dose to the central and the paracentral region. And then after putting the Foley's catheter, we write the a template obturator over the central tandem. And then we fix the central tandem with the help of the screws, as you can see here, with the help of a screwdriver. Yes, we can fix the screws here. I don't know why it is causing jerks in between. Then once you write the template over the central tandem, we fix the template onto the skin with the help of sutures, as you can see here. And we should make sure that this is symmetrical in position, because if it is deviated to one side or the other, then the implant quality will not be very good. So as you can see here, the suture is being applied to fix it on the skin, and this suture is taken to the skin and the subcutaneous tissue, so that you have a good amount of the tissue to fix it. Otherwise, you can have a tear in the skin just when there is a traction. Similarly, on the other side also, you apply another suture so that it becomes fixed and opposed to the perineum. You can apply 2 more sutures on the downsides, but usually 2 are sufficient, because once you put needles, it fixes the template on its own. So now the suturing is complete, and then we again do the transrectal ultrasound so that we can see the position of the uterine, the central tandem. As you can see here, this is the central tandem, the post-acoustic shadow, the bladder, the Foley's bulb, and this is what we are going to implant: the cervical tumor and the part of the lower part of the uterus. In this patient, it was slightly involved as per the imaging. So this is how we put the central tandem and make sure that it is in the correct position. And then we, this is the bladder, just to demonstrate, this is the bladder. and then we start putting needles. Always start from the anterior side, because if you put the posterior needle first, then the ultrasound images will be obscuring the other anterior needles. So start always from the anterior side. Just you can see the anterior needle which is being put. Length depends how much the disease or the cervical length is. Usually we need to go beyond 3 centimeters beyond the cervical os, because that's the normal length of the cervical the cervical os. And so if there is a disease, then we can go up to like 4 centimeters also. But as you go higher, the chances of gut perforation or gut injury are little higher. So, but I usually keep in between 3 to 4 centimeters. But rest, it depends about the disease extent. Similarly, you put the other needles in the obturator all around, as you can see, but keep the posterior needle for the end, because otherwise that might just go into the rectum and it might obscure the other needles as well. So now you can see the central tendon, the 2 needles you can, one needle here and similarly one needle here, So you see the needles and you make sure that they are not into the rectum or the bladder, So that's the purpose and the benefit of using the transrectal ultrasound. It's very useful now. Then you start putting needles onto the template holes, and some of the needles are divergent to cover the wider part of the pelvis, so that you can cover the parametrium and the paracental disease. So that's the advantage of the MUPIT, because the other templates do not have this kind of wide divergence. And similarly, one by one, keep the implant needle insertion asymmetric. Like if you put a needle on this side, then opposite side also put the same needles, so as to keep the symmetry same. And now you can keep seeing on the ultrasound images, so that you can see if there's needle into the bladder or the rectum. Just like you can see the needles are being put. If patient has a lateral period, then you need to keep the implant a little laterally also, just like in this patient, they are just almost into the lateral side. And again, to see the ultrasound image, as you can see, the multiple needles almost covering the tumor very well, and cervix and tumor very well, and they are equally distributed. That's the benefit of using templates, because the holes will give you guidance to implant the tumor. And then always do at the end of the completion needle the insertion, always do a PR examination, so that you can see any injury of the rectum and if there's a needle in the rectum. Always connect the Euro bag and to the Foley, so that you can see if there's a bladder injury, you can notice the hematuria. And if there's no hematuria, that will be a good thing to notice, because urine will, as you can see, urine is very clear here. So that means there's no needle into the bladder. Then you apply the screws over the needle, so that they don't move inwards, and then apply the outer plate of the template. Sometimes this can take a little time, because it needs a little bit of expertise, and sometimes it can take more time than the actual process time. Initially we used to struggle a lot, because you have to match all the holes of the inner template and the outer template. So once the template is fixed, outer template plate is fixed, you apply the screws on this so as to fix it. And once you fix the 2 plates, the needles won't be able to move inwards or the outwards. So that's the purpose of using the 2 plates, that they prevent the inward and the outward movement of the needles. So this is the completed. Then we do the simulation. As you can see, the various needle position, none of them is in the bladder. Some of them are near to the rectum, but they are not to the rectum. And see from the cranial end of the implant, you can see here all the needles. You can see the bladder is slightly pushed on one side, because it is full. And you see the rectum also. Slice by slice, we contour all the organs, and then you can play around. This is the 3D reconstructed image of the implant and the needles and the bladder and rectum and the colon. So you can move it in all directions to make sure that it is in the perfect position, and none of the organs is having the needles. As you can see now, the bladder, the rectum, the colon, and the various needles. And once you ensure that it is in perfect place, then you start the hand of the physics to create a dosimetry. I will not go into the dosimetry because that is going to take a little time, And so that almost completes the process. I'm sure only the procedures, so that because many people hesitate to perform this implant, thinking that it's a traumatic and it is like, but I think so with the help of ultrasound guidance, it becomes very, very easy. I find it very easy by, taking the assistance of the ultrasound. So that's how it is done. I think I'm done. If there are some questions, then we can take the questions. I could say only this because it was only 10 minutes time, So I didn't want to overshoot the time,
Excellent, Professor Dean Sharma. Very good and lucid
Thank you, sir.
wonderful description of MOPIT. I think the institute should get trained under you for.
Sir, no, sir. Sir, actually,
yeah,
every process I learned something, sir. So even now, when I do this, something other I knew, learned something new from every process. So I'm just the student. So
not that. See, your generation doesn't know much about these type of procedures.
Sir.
It's only the older generations who have been doing that. I
Sir,
think the
sir.
institute should be brought to this kind of procedures and then taught them.
Sir.
Thank you, sir.
Sir. Okay, sir. Thank you, sir. Thank you very much, sir. Thank you, sir.
Yeah, request Dr. Giri to please introduce Dr. Somashekar.
Good evening, Dr. Somashekar doesn't need any introductions. Already he's a famous person, very popular among surgical oncologists and a gynae oncologist. He's a very good oncosurgeon, post-open and robotic, and he's a high-tech specialist. But today he'll be going and talking on pipe tech. Also, he's no less pipe tech specialist. So now, the stage is yours.
Thank you very much. It's a 10 minutes video, but if you just see video, you may not actually like it. So I have also introduced a little bit of data so that you will feel happy, and you will get actually some good message rather than just seeing a video. But I will try to keep it in the whole time. We know that those who deal with peritoneal surface malignancy, advanced stage CA ovary, must know more than one modality to treat the peritoneal extent spread of advanced ovarian cancer. Number one, you must know how to do a complex upper abdominal cytotoxic surgery. Number two, you must also know how to put an intraperitoneal port for normothermic intraperitoneal chemo, EPIC. You must also know early post-operative intraperitoneal chemo through the catheter. You must also know HIPEC if that's a right patient as per the OV HIPEC trial. And those patients who are not amenable for cytoreduction or recurrent or CC0 cannot be achieved, or patient performance status doesn't permit you to do 10 to 12 hours of cytoreduction, then the palliative procedure PIPAC must be known. It's a pressurized intraperitoneal chemotherapy where we all know that if you add chemo to IV, peritoneal concentration is very low. If you add chemo to intraperitoneum, concentration is 10 times. If you add heat, penetration is more than 10 millimeter. If you add pressure to that by peritonoscopy and pneumo, then the penetration is much more than that. And nanoparticle aerosolized chemo, if you leave, that is when the maximum palliation benefit can achieve. So for a setup of PIPAC, this is how the OT would be required. You need a Book-Walter retractor. You need a high pressure injector. This is available in your cath lab and your CT scan and MRI room. You need to take that. And then you need a Capno pen produced by Capnomed from Germany. The standard for ovarian cancer is doxorubicin and cisplatin, 7.5 milligram per meter square, 1.5 milligram per meter square. So this would be 150 plus 50, 200 ml. So how is the mechanism? There is a pressure given by pneumo, carbon dioxide pneumoperitoneum. Then this particular Capno pen aerosolizes microparticles of the chemo, and then you leave it for about 8 minutes and then allow it to stay in the peritoneal cavity for 15 minutes. So what I will do is I'll show the videos as I go, and then I'll compare with this. Remember, since it is under high pressure that you would see, you need to actually have a special type of balloon catheters. Otherwise, there will be extravasation of the drug, and sometimes peritoneal implantation may happen, which I had in one patient, unfortunately. So it is a palliative procedure in peritoneal carcinomatosis, which is quite often used. And this is how you need to use. These are available by Access device in India, not very expensive. They come in 5 mm and 10 mm. So make sure you use a balloon catheter. So you inflate and check this balloon catheter are in order. Make sure you have kept a pressure injector ready and look at the settings, 0.5 ml per second and about 139. Capno pen is the one which aerosolizes and prepares the PIPAC, pressurized intraperitoneal aerosolize. It comes with a pre-attached connector. If you connect this to a high pressure connector and then you put the chemo, that is when the whole thing goes up. Second thing is you must know what is the operational checklist. Before you proceed, you must know right patient, right chemo, PCI index, biopsies from 2 to 3 different quadrant is taken, aside is sucks and cytology is taken, and then you actually put up the pressure injector. You can see that how you access the abdomen, then look at the extent of the disease, and then you map out the PCI in this patient, and no additional lysis is usually permitted. Don't do that. And if you injure the bowel, you can't do PIPAC. It's not like HIPEC or other, then there will be fistulas. Just inspection, PCI assessment, ascites fluid is all sucked and sent for cytology. Then you put a book called retractor and a camera. You just need 2 arms. And once you do this particular thing, then 0.5 ml per second and 150 ml. I told you 100 plus 50 ml. Then the remote sensor. Nobody says in the OT. Everybody comes out of the OT. And then through a remote pressure, you have to do that. And you need to have a HEPA filter in the OT. And we usually use a buffalo filter to put it. Now you can see that then the snowstorm, we call that Swiss snowstorm. This particular capnopen produces this aerosol at a very nano micro parts. It takes about 7 to 8 minutes to inject this. Now this aerosolized high pressure chemoparticle go and attach itself everywhere. After you finish this in 8 minutes, you control it, you look through the OT and then you control this particular area for 15 minutes. So the advantage is there is no systemic absorption that happens, so no side effect for the systemic absorption, and very good response is available for this particular patients for us to go ahead. Sorry, I just missed it. I will go back there. So if you look at the advantages, then we would actually note are as actually enlisted in our study. So this is something very important. When you start a remote application, initially there will be 1 or 2 drops, then the snowstorm starts. So wait for that few seconds before the snowstorm starts, and you can visualize this whole thing, and then the particles are carried and then they go and sit on this particular area. So we did the first Indian PIPAC study in the ovarian cancer and published it. Then we did a randomized control trial, the only randomized control ICH GCP phase 3 trial, which we registered in India. This is the CTRI trial, which we registered in India. We did 1 arm IV chemo, another a PIPAC. We published this in Pleuron Peritoneum. What we analyzed not only response, quality of life, overall survival, but also a assessment of the global indicator. So you can see that there is something called as PRGS score, peritoneal regression scoring. As you respond, the ascites goes off first. So we did this particular trial where we did 3 PIPACs in recurrent ovarian cancer. And you can see most of the time, 67% left. Palmer's point is where we access. And this particular is the number of cycles, 55 patient on the other side. You can see that we had 69% response. You can see first PIPAC, second PIPAC. First PIPAC studied, second PIPAC, disease gone, third PIPAC, everything is saponified and then hyalinized. Look at the CT, tons and tons of disease, first PIPAC, second PIPAC, third PIPAC, almost looks normal scan. And when you do this, you can see by first PIPAC, the whole nodule go off, ascites goes off, patients start eating. Look at this particular volume of disease, platinum-resistant ovarian cancer, very high volume of disease. Before we started, palliative cytoreductive surgery is not possible. Here comes the balloon trocars, and then we did a PIPAC. Look at the first PIPAC. The same patient, all disease has become flat, hyalinized, completely responded. Patient's appetite comes back, and then we don't give IV chemo during this time. So the mean follow-up we had for about 2 years, 80% of them had a response. When we assess the quality of life, functional score, symptom relief, global health score, this was superior to IV chemo, and no grade 3 toxicities, very minimal grade 1 toxicity. In only 1 patient, we had an implantation of the tumor at the trocar site, 1 patient, and no other patient we had. So in conclusion, PIPAC is feasible, effective, very tolerant, morbidity is very low, mortality is very low, and excellent outcomes are available, both in terms of response, overall survival, ascites, intractable ascites relief, and then quality of life with this. Thank you very much.
Thank you, Dr. Somashekar. And Dr. Soma also conducts these workshops on PIPAC in case any of you are interested in learning about it. When is the next one, Dr. Soma?
Actually, I'll probably plan sometime in December. No, twice a year we do that. And there, ISSP, if you want to do PIPAC, you must be certified by International Society of Pleuron Peritoneum. So this course is mandatory to attend and then get certified.
Okay. Thank you so much to all our video presenters, Dr. Anupama, Dr. D.N. Sharma, and Dr. Somashekar. Thank you so much. And with that, we would like to conclude today. And I thank all the faculty and all the delegates who helped in making us, make this conference a great success. We had about 300 attendees today in all, and would like to thank all of you for bringing in light all the gray zones that we discussed, and the great video presentations with the fantastic keynote lectures and the panel that we had. And we look forward to seeing you all in equally interesting discussions tomorrow. And we have a great day planned tomorrow, and looking forward for your presence tomorrow. Thank you so much.